Very good morning. Warm welcome to all of you on behalf of the organizers, Day 3 of the CHIP Summit 2023. After 2 scintillating days of scientific sessions, we move on to the first session of today morning, the adjunctive pharmacotherapy in CHIP. And may I please invite the chairpersons, Dr. Manu Verma, Dr. Rajesh, Dr. Balakrishnan, and Dr. Naveen Matthew, please. For the kind attention of the chairpersons, the timing is 7 plus 3 minutes. There's a small misprint. It's 7 plus 3 minutes. And over to the chairpersons now. What do you, sir? Dr. Japi to present first.
Good morning, dear friends. We are about to begin the session, and first speaker is Dr. Jaber Abdullakoti. The topic is where is he got glimmer of hope in worsening heart failure. I'm not giving any big introduction to Jaber. Everybody is well aware about him. Jaber, podium is yours.
Thank you, Manu.
Kindly go
Thank
ahead.
So, the worsening of heart failure is a major problem in the trajectory of heart failure. Every heart failure patient is destined to develop a worsening. And once they worsens, and the definition of worsening is need for hospitalization, need for urgent emergency room visit, or even OPD-based change in the diuretic dosage, or sometimes they may get a shot at the OPD of a IV diuretic and they go home. That's the current definition of the worsening of heart failure. And when the patient develops a worsening of heart failure, at least half of them develop readmission within 30 days. And one heart failure hospitalization begets another heart failure hospitalization, and the mortality increases. So this is a problem. This increases the mortality, and this increases the cost of therapy. And if you look at the current guideline recommended medical therapy, all the best medical therapies, the Paradigm Heart Failure, DAPA-HF, Emperor Reduce, Galactic HF, all these things, in the active arm, somewhere around 10 to 12% of the event rate. So that means our treatment is still suboptimal. It's not perfect. And with the quadruple therapy, 1 in 7 develops a primary outcome. That is despite the use of all the 4 pillars of therapy. So we need another therapy. So the current therapy, neurohormonal modulation, aimed at modulating the sympathetic nervous system, RAS system, or the neprilysin or the SGLT2 inhibitor. And we never thought of changing this thing or modulating this thing. That is a nitric oxide soluble guanylyl cyclase cyclic GMP signaling, which is important in the endothelial function, vascular function, myocardial function, and cardiac remodeling. So in heart failure, there is oxidative stress, there is endothelial dysfunction, and a reduced bioavailability of the nitric oxide. So this leads to impaired vascular function, impaired myocardial function. And if we modulate this and increase the availability of nitric oxide, that itself stimulates the soluble guanylyl cyclase, increases the cyclic GMP production, and which can lead on to a decrease in the hypertrophy and fibrosis of the myocardium, improves the endothelial dysfunction, improves vascular stiffness, which helps in heart failure. So it reduces the cardiac inflammation, myocardial fibrosis, myocardial hypertrophy. So it improves the structural alterations in the heart failure. It improves the blood vessel functioning or the blood vessel properties, which produce vasodilatation. It reduces the systemic inflammation. Improves the renal function. It reduces renal fibrosis. It improves renal blood flow. So all these things together should really help in heart failure. Now we can look at whether it's really helping the heart failure. The Victoria study, symptomatic chronic heart failure, NYHA class 2 to 4, predominantly class 3 patients, ejection fraction less than 45%, on available heart failure therapies except SGLT2 inhibitors. And mandatorily, a worsening heart failure event, heart failure admission in at least within last 3 months in 67%, 17%, 3 to 6 months, and IV diuretic within last 3 months, 16% patients. No run-in period. And this is really a sick subgroup of patients. 41% NYHA class 3. When you compare with the other major studies, higher ND-proBNP, and cutoff EGFR is 15. And it is 100% worsening of heart failure patients. You can look at the comparator arm event rate close to 38, when the others it is 13 to 20 only. So that means it's a sick group of patients, no doubt. And good penetration of the baseline therapy, beta blocker 93%, ACE inhibitor 73%, MRA 70%, ARNI 14%, ICD 1 in 3, and biventricular pacing 15%. So all the best therapies available at that time. So well treated with guideline recommended medical therapy. 10.8 months, number needed to treat is 24 to get a benefit in terms of primary composite endpoint reduction, predominantly driven by the first heart failure hospitalization, which appeared by around 4 months. And if you look at annualized number needed to treat for primary endpoints, it is almost similar or a little better than the other major therapies except the eplerenone and empagliflozin. And early and sustained reduction in the NT-proBNP. Now all the recent trials in heart failure looks at the NT-proBNP levels, and the reduction is correlated with the clinical outcome. It produced a significant reduction in the NT-proBNP level. And the treatment limiting factors, what is the impact? No significant effect on blood pressure, no significant effect on sodium and potassium level, no significant effect on the renal function. So in fact, these are the limiting factors of the currently existing guideline recommended medical therapy, which does not produce much problems for putting the patient on vericiguat. So favorable safety profile, 90% achieved the target dose of 10 milligram in the Victoria trial in 12 months. No significant difference in symptomatic hypotension. The rates of AEs and SAEs were almost similar to that of the comparator placebo. Dosing, you can give it in patients with hypotension, renal impairment, even in those patients who are at the risk of hyperkalemia, though the blood pressure cutoff was 100 in the Victoria trial. Start with 2.5 milligram after 2 weeks. If the blood pressure is more than 100 and no problem, you can increase it into 5 milligram, then to 10 milligram, which is the target dose. And benefit was observed irrespective of the background therapy, including ARNI. So it's recommended for a comprehensive medical treatment in patients with worsening heart failure with all the background medical therapies. And it's a class 2B recommendation by the ESC 2021 guidelines, AHA 2022 guidelines. This is my experience with vericiguat. Number is less, 40 patients. I could put 63% of the patients on the recommended dose of 10 milligram. Ejection fraction close to 50%, less than 30% ejection fraction, another 50% between 30 and 40%. Diabetic more than 50%, 1/3 hypertensive, 1/3 with CKD. And symptoms improved in more than half, 57%. This is a sicker group of patients. You can see when you look at the other medications, you can see that diuretics, 97% were on diuretics, 90% on SGLT2 inhibitors, 90% on beta blockers, MRA 70%. And the other non-pillar therapies like ivabradine, digoxin, nitrate, hydralazine, all these things around 30% and ARNI in 26%. So well-treated patients and sicker group of patients. And the outcome, the benefit, the reduction, the repeat hospitalization, it is 15% only in this. And rehospitalization in worsening of heart failure. This is not a randomized data, it's only an observation, but there was a reduction and the patients tolerated very well. Thank you so much.
Thank you, Dr. Jaber, for the crisp presentation. One thing is that, when we discuss about the vericiguat with the ARNI, the blood pressure reduction is not that much of the ARNI as was the, we had to stop ARNI in many patients with borderline hemodynamics, reduce the dosage, or even had to stop because of the worsening of the renal functions. This doesn't have that. What's your observation from your?
I was a part of a registry also. There the cutoff was 100 millimeters of mercury blood pressure and a hemoglobin cutoff of 11 gram per deciliter. Patients tolerated this drug well. Even if the blood pressure is 90, that I have started the patients on patients who have blood pressure 90 because they cannot tolerate any other drug. So this drug is well tolerated, no adverse effect, no specific adverse effect.
Dr.
Can I-
Jabir, very nice and short, quick overview of the vericiguat, the new molecule that is in heart failure. What do you feel will be the future of vericiguat? Should we need to really wait for class 3-4 symptoms? Or this drug doesn't have any practical side effects? Catching them early in the natural history of heart failure, see, class 1 and 2 patients doesn't have, and these modulations do happen quite early in the natural history of heart failure. Can you tell us what do you feel and what are the available data? Anything, say somebody with a class 1 or 2 and he will have contraindications for other established pillars for therapy, but this is a molecule that can quite
I
early
think
be initiated in the natural history of heart failure.
it's an extremely important question. For example, if the patient, as you rightly pointed out, the patient with a renal dysfunction, hyperkalemia, hypotension, no other therapies can be given, and he is not on any other pillars of therapy, I of course will start them on vericiguat and see whether it will reduce hospitalization. That itself is good. Then, if a patient is stable, asymptomatic on the guideline recommended therapies, whether to add a vericiguat, right now we don't have a data. If there are newer trials coming up, if a data which shows there is improvement in the remodeling of the heart, then I will definitely start this drug quite early. And the cost of therapy, 90 rupees per tablet.
So one more Jabir here. One more promising therapy coming up. But do you think it will ascend in the ladder? And maybe that's a similar question that you asked. Your 60 patient feel. What is the feel of the medicine?
Feel is very good. Certain patients tell us that after starting that drug, I feel better.
Okay.
Absolutely no side effects.
Because
So
initially we had some problems. We had to withdraw because of hypotension and all. Did you have to withdraw in anybody whom you
No,
started?
only withdrawal was basically because of economic reasons. The patient themselves, 4 patients withdrew. Otherwise, no.
The 4 pillars of heart failure, the main problem is when you start together, the renal dysfunction. This is one advantage of this drug can be given in renal failure without much hypotension.
Yes.
So that is the 5th pillar of heart failure management.
Thank you.
We'll move on to the next topic on newer antiplatelet therapy by Anil Balachandran.
A very good morning to you all. My CHIP subset task for the day is to rather review antiplatelet therapy in 2023. And having said that, we all know that the complex PCI, especially the CHIP subset, involves patients who are at high ischemic risk. And we know very well that they have a early as well as long-term risk of ischemic events, and the risk spans up to 30 months in timeline. And the risk of stent thrombosis is around 3 times, and the risk of re-MI is around 2 times. So they require a strong antiplatelet therapy. And having a review of the current available antiplatelet agents, we know that ticagrelor has got a slightly, they have a slight edge over the other agents with regard to the hard endpoints. Having said that, prasugrel is making a comeback with the current trials, and even in the European guidelines, prasugrel has got a special mention, and it has got a slight advantage regarding mitigation of stent thrombosis also. Clopidogrel, the good old friend of ours, is still having a big role, especially in particular subset like the high bleeding risk group, patients on oral anticoagulation requiring an antiplatelet therapy also. So this is one thing which was mentioned in one of the talk by Dr. Venu Menon, that is the use of crushed ticagrelor, and that is one way of increasing the bioavailability as well as the potency of ticagrelor, especially in patients in cardiogenic shock or patients who are unable to take oral medications. So we know that most of the peri-PCI complications occurs within the first 6 hours of the PCI, irrespective of the complexity of the procedure. So a strong antiplatelet therapy during that period is pivotal in the success of the PCI. So with that, we have the new IV cangrelor. It's a IV antiplatelet with a short onset and short offset of action, with a maximum platelet inhibition of more than 98% and return to baseline platelet function within 60 minutes. So it is a ready reckoner if you want a strong antiplatelet action and a swift one also. So it is especially suitable, especially if you have a CHIP subset patient who is very sick, who is intubated, who is in cardiogenic shock, who has a nausea or vomiting. We know that patients on morphine have a less bioavailability of many antiplatelet agents, and patients who are not adequately pre-treated with the oral antiplatelet drugs. So they are also benefited with the IV cangrelor. And in the talk by Dr. Venu Menon, he was mentioning IV cancelor has become a routine for high-risk subset patients in the Cleveland Clinic subgroup. And someone has gone a step further. That is, they have taken the best of both worlds and they have looked at the use of crushed ticagrelor versus cangrelor, two drugs which have an immediate onset of action in PCI, and they have found out that they have a better and earlier antiplatelet action with no drug-to-drug interaction, with no much increase in bleeding. So this is one cocktail to look for. So it's always good to have an idea of how to have a transition of IV to oral. We all know that clopidogrel and prasugrel belongs to the same group as cangrelor. So it is better to stop the cangrelor and then start clopidogrel or prasugrel because there could be a reduction in the number of available receptors. Whereas ticagrelor can be started at any point when the cangrelor infusion is going on. Then another new drug which is available is selatogrel. This is a novel, potent, reversible subcutaneous P2Y12 inhibitor. The highlight is ease of administration. So it could be of use in the pre-hospital or in the peri-procedural setting, especially in unconscious or emergency patients, just like cangrelor. So this is undergoing phase 2 trials, and we are expecting good results in the coming years. And there are a lot of antiplatelets which is going on in the pipeline. And we are expecting a lot of data, a lot of trials coming on, and even our good old GP2B3B inhibitors is undergoing a makeover. So we expect a lot of data. But discussing thrombotic events, we should never forget the importance of bleeding in peri-PCI events. And this shows that actionable bleeding has got the same 2-year event rates, or maybe more than that, regarding a coronary thrombotic events. So there is a new subset in interventional cardiology, that is the high bleeding risk, and there have been a lot of strategies for the high bleeding risk subset. You have a variety of choices like aspirin with the de-escalation of the antiplatelet therapy, or monotherapy with clopidogrel, ticagrelor, or clopidogrel per se. All are data backed up, and you have a choice regarding a particular patient. And what is new regarding P2Y12 is the one thing which is new, which I have found, is that regarding the pre-treatment of antiplatelets in patients with non-ST elevation MI. ST elevation MI, you should have the loading dose. But in non-ST elevation MI, if you are planning an intervention within 24 hours, the current guidelines give a class 3 recommendation against routine pre-treatment with antiplatelets. The current recommendation is if you are taking the patient for a coronary angiogram, do an angiogram, define the anatomy, then give the loading dose. So that is one change which has been there in the current guidelines. So if you are making an antiplatelet prescription, it is more of a custom-made or tailor-made for the particular patient, taking into consideration the ischemic and bleeding risk factors, and look at the various risk score, and based on your high ischemic or high bleeding risk, you can have an idea, or you can choose an antiplatelet strategy. And more important is that the procedural considerations are also given due importance, because a properly done, meticulously done, image backed up procedure helps to reduce the duration of antiplatelet therapy. So in a nutshell, if you want to have a concise view of antiplatelets in 2023, this shows everything, taking into consideration the individual bleeding and thrombotic characteristics, as well as the complexity of the PCI. And if you have a very chip or complex subset of PCI, extended therapy of dual antiplatelets is given a 2A or 2B recommendation beyond 12 months. And if you want to have a pre-treatment, again, in NSTEMI patients, it is a class 3 recommendation. Short duration antiplatelet therapy, if you want to have an aspirin-only strategy, it is given a 2B recommendation. If you want to have a clopidogrel-only strategy, it is having a higher recommendation of class 2A. So this is in a nutshell regarding antiplatelets in 2023. Thank you so much.
Thank you, Dr. Anil. A very crisp slides. And one thing about this regarding the cangrelor. Cangrelor, you mentioned about the use of cangrelor in the initial phase. Again, you can be used as a bridge also, you know.
Exactly.
Especially patients on a Friday evening, the cardiac surgeon will say, we will take it up on a Monday morning, stop all the antiplatelets, and the patient will be stuck up with the cardiologist. And we are very scared to stop all the antiplatelets and keep the patient just on a heparin. I think it will be very relevant if we can start a cangalor and if we are ready to. And surgeons should ready to understand the physiology as well as, many surgeons are reluctant to take the patient like that with a bridge therapy. The cangalor will be a very good tool to use as a bridge therapy.
In fact, cangalor was introduced as one of the main uses of cangalor was used as a bridge to surgery.
Absolutely.
But I doubt how many surgeons would be able to accept even though ticagrelor is accepted as an early reversible agent. People are not very happy in continuing ticagrelor. They want at least 5 days of holding of ticagrelor also. Very particularly.
Now we started doing the same thing. Like even for a non-cardiac surgery, you have to stop the drugs 5 days prior, and patient is waiting for the surgery. Patient is in the initial phase of the stenting, like in the first 3 months. Stopping all the antiplatelets and taking up for a surgery, it's quite risky. I think a bridge therapy with a cangalor will be very useful in such cases.
Regarding NSTEMI, what is your current strategy? Because we all know with aspirin and clopidogrel, with the newer insights, will there be a change in our strategy?
The data is that they have looked at the data and they have found that nowadays in most of the centers in the West, the NSTEMIs are taken for an early invasive strategy. So if you are taking up for an intervention within 24 hours, they have looked at the data from the Atlantic as well as the ACOS trials, and that has led to the recommendations in the current guidelines. So they have found that there is no further advantage for loading in such patients. Obviously, they have made a mention that loading with ticagrelor per se has shown some advantages with regard to stent thrombosis. But overall, there is no extra advantage for loading in patients who are being taken up for a early invasive angiogram. I doubt whether what is the strategy overall, whether we take NSTEMIs within 24 hours for an angiogram or not. If you are taking an NSTEMI for an angiogram beyond 24 hours, the recommendation remains the same. You should load it.
Now, is it ticagrelor or clopidogrel in NSTEMI?
Depends.
Because currently we use ticagrelor more for a STEMI and clopidogrel for a NSTEMI. That is the usual practice. So that may
But
need some
in
change.
most of the recommendations, ticagrelor and ticagrelor particularly has got an upper edge over clopidogrel in many of the recommendations.
Yeah, in your practice, what is the use of prasugrel? And recently I happened to see a prescription from abroad of 3.5 milligrams of prasugrel for a patient who is 75 years, underwent an LAD angioplasty after an acute myocardial infarction. That is 2 days, 48 hours after the infarction. But I was surprised to see that 3.5. When I look at him, he is 75 years, doesn't have any stroke in the past, but they gave, instead of ticagrelor, prasugrel was advised. And it was very difficult to convince him to change over to ticagrelor also. And I didn't see that. This is the first prescription I see, 3.5 milligrams of prasugrel for that patient. One. Second thing, what is your practice of complex PCI with prasugrel? Loading dose and continuous subsequent doses. And as you said, in surgeons, when I talk to the surgeons about 5 days stoppage of ticagrelor, they say you give aspirin and ticagrelor. So they want the ticagrelor, okay, you may be right that it may be effective within 72 hours, they can do the surgery, but the aspirin they are concerned about. And some of the surgeons say they have a lot of bleeding and they don't want to mess up. So that is why they want that 5 days, this thing.
Regarding the first part of your question, prasugrel there is no doubt regarding the antiplatelet potency and the effect of prasugrel in mitigating stent thrombosis per se. In fact, after the ISAR React 5, the latest ESC guidelines have given a special mention for prasugrel per se. And a lot of people have looked at the data with 5 milligram of prasugrel in the long term, because the bleeding was one of the important concerns regarding prasugrel. And in fact, this is the current trend in antiplatelets, because there are trials with ticagrelor 45 milligram, ticagrelor 60 milligram. They are reducing the overall dose of ticagrelor. And in fact, earlier 60 milligram was advocated beyond 1 year. Now people are looking into 60 milligram of ticagrelor as after the initial 1 month or 3 months. Patients have to be maintained on 60 milligram of ticagrelor also. So we are expecting results regarding that trials per se. And overall, I personally feel prasugrel is one drug on a properly selected patients. Prasugrel still has a role.
Should you stop aspirin prior to CABG? Because 75 milligram aspirin should be continued till CABG, because otherwise pre-procedural events are high. That is why this advice. All my patients till surgery is continuing 75 milligram aspirin.
No, the problem is with the newer antiplatelets. The surgeons are more worried about the prasugrel as well as ticagrelor. That they want to stop it.
Dr. Anil, a nice discussion we have generated, and I would like to get your opinion regarding what is your antiplatelet of choice. Say after 1 year of stenting or 1 year of CRG, you just want to continue single antiplatelet, and what do you feel will be the future of aspirin?
With the available data, I personally feel my personal practice is to continue clopidogrel per se, because overall, whatever said and done, the incidence of erosive gastritis with aspirin is very high. And with the data, even if you look at the data per se, clopidogrel is given a more higher recommendation. That is, now world is going towards aspirin-free strategies actually. In most of the trials are going for aspirin-free P2Y12 only strategies. Maybe that may be the future per se.
Is it the right direction, or no takers for aspirin and no major trials is going to happen with aspirin as the major backup? Or say, are we losing out because in the overall population strategies, we may be losing out on a lot of patients if we, so what is your personal choice will be, you feel aspirin is really outdated its utility and...
No, there is no doubt regarding the fact that aspirin is a potent antiplatelet molecule. It is time tested. But whatever current data is coming is towards P2Y12 inhibitors, and overall.
All these trials are done for what? For industry. Industry is driven all these trials. So that is why aspirin is the cheapest drug. That is why aspirin to be taken out and the other drugs to be promoted. That is why when a patent goes away, that is yesterday was Ramesh Tugubati was telling in GIS, he was telling that when the patent goes away, they will do another trial telling that this is only for this drug. That means your drug, which is actually expensive, will remain in the market for a long time with a patent, so that industry will be remaining long. That is the only basic aim. Is actually aspirin is a drug you can continue for years.
Another thing is that the combination of aspirin is cheaper than
platelet.
So even if you ask the patient to take a single antiplatelet, next time they will come say, I'm taking the old medicine only because it is cheaper.
In fact, in that sense, many of the patients are continuing dual antiplatelets, even if you write a single antiplatelet.
Sorry to interrupt, sir. May we move on?
Next speaker is Dr. Sunil Shivadas, and he will be discussing on the novel oral anticoagulants. Dr. Sunil.
Thank you. I'll be speaking on the novel anticoagulant. I've been given 5 minutes, so I'll be just briefly running through. The topics covered today will be a brief introduction to the NOACs, newer indications, the newer horizons, that is in the LV clot, triple therapy, mechanical valve, antiphospholipid antibody, rheumatic mitral stenosis, and some 2 newer NOACs. Brief introduction, any oral agent which is non-vitamin K antagonists are classified as NOACs. First introduced in 2010, that is dabigatran was first introduced in 2010. The main use by it came was because it was predictable action, no dose adjustment, safe, the presumed safety, and no routine monitoring. The brief, first one to come was dabigatran, which is a direct thrombin inhibitor, the rest remaining a factor Xa inhibitor. The main advantage is that time to reach peak action is around 2 hours, so there's no need to overlap with heparin. Now, dabigatran has got no liver metabolism, and it is mainly excreted through 80% is through renal, and the least for renal excretion is apixaban. Now, one thing about diet, dabigatran is usually combined. The Pradaxa molecule comes with tartaric acid, so it needs an acidic environment. So, if you with food, higher dose 10 mg and 10 mg and above of dabigatran should be given empty stomach. Well, rivaroxaban, it is preferably to be given with food, because it increases the bioavailability. Mechanism of action, as we know, the coagulation cascade, the intrinsic and extrinsic pathway. All these molecules acts in the common pathway, factor Xa and thrombin inhibition. So, and while vitamin K antagonist acts in the alpha carboxylation of factor 2, factor 7, factor 9, and factor 10. Now we come to the newer indications. See, in the LV apical clot, the 2014 guidelines of AHA recommends 3 months of oral anticoagulation. while the ESC recommends 6 months. In 2022, the AHA has modified it, saying that for MI or ACS, you should give for 3 months, and in DCMP with LV clot, you should give for 6 months. After the therapy, you reassess, and according to if the presence of clot, further continuation of anticoagulation is needed or not. Now we have 32 trials comparing Novax with warfarin in LV apical clot, of which one is a meta-analysis. There are 3 randomized controlled trials, 3 case series, and 23 observational data. From the randomized controlled trial, which was published 2 years back, it appears that the Novac or DOACs are non-inferior to warfarin with lesser thrombotic, and there's no significant bleeding complication. The pooled odds ratio for Novax, which warfarin, was that they had 11% thrombus resolution compared to 15% more bleeding risk in the warfarin group. Some observational data also shows that Novax, in the first month, Novax had a better thrombus resolution, while at the end of 1 year, the warfarin had caught up. So faster resolution is seen in Novax. This is observational data, but and there are 4 major trials which are randomized controlled trials will give you more clarity on this. Now, triple therapy. Most of us patients on post-PCA have atrial fibrillation. So how long and how do we go about doing it? The routine non-MI patients, the triple therapy should be, you should give an anticoagulation, clopidogrel plus aspirin till discharge. Then dual therapy, that is clopidogrel plus anticoagulation for 1 year, followed by that only anticoagulation. Now, between Novax and warfarin, there are 4 randomized controlled trials, VOICE trial, Augustus trial, Pioneer, and Reload PCA. All of them favor using Novax over warfarin. And we have a meta-analysis also, which included more than 1 lakh patients, which shows that there is a benefit of Novax over warfarin, mainly driven by less bleeding complication. Now, in higher ischemic risk patient, you give triple therapy for 1 month and followed by double therapy that includes a novel anticoagulation plus clopidogrel for 1 year. After that, oral anticoagulation. In people who have low risk, in this subset who have low risk for bleeding, we can give oral anticoagulation plus clopidogrel also. In people with high risk of bleeding, triple therapy is recommended only till discharge, then double therapy for 6 months, and then after that, only anticoagulation. Now, who are high risk ischemic? High risk subset are who have had previous stent thrombosis, diffuse multivessel disease, CKD, more than 3 stents, more than 3 lesions treated, bifurcation stenting done, stents length of more than 60 mm, CTO, left main and proximal LAD. While high bleeding risk have people who have short life expectancy, malignancy, poor mental state, end-stage renal disease, advanced age, bleeding, anemia, alcohol abuse, CLD, and previous significant bleed on dual antiplatelet. Now coming to mechanical valve. Initially, along with the RELAY study, RELAY-Align was evaluated. This showed that dabigatran had higher thrombotic risk in mechanical valve. So it was a use of Novax in mechanical valve was shelved. Now, PROACT trial, which was published 2 years back, actually was terminated. PROACT, actually they used Onyx. Onyx patients needed a lesser anticoagulation. You can, for them, therapeutic anticoagulation is INR between 1.5 and 1.7. Anything more than 1.7 is acceptable in aortic valve for Onyx valve. So, PROACT group tried to evaluate Novax. Rivaroxaban was tried, apixaban was tried, and this trial was terminated because 4.3 times, 4.2% of patients had thrombotic events compared to warfarin of 0.3. Now, antiphospholipid antibodies, the guideline says warfarin plus antiplatelets. Aspirin has to be combined with the thing. But there are some few subsets like who were not triple test positive or who didn't have arterial bleed, who were deemed less procoagulant state, and in these subsets you could try Novax. But the TRAP study, which was also terminated prematurely because the rivaroxaban had higher thrombotic events. Now, valvular rheumatic heart disease, this was presented by Karthikeyan, Dr. Karthikeyan in ESC. 4,500 odd people with valvular rheumatic heart disease with in addition to that, mitral valve area of less than 2, LA clot or Church-Vass score of more than 2. were enrolled in this randomized control trial. They compared rivaroxaban 20 mg with VK. In this, although the bleeding risks were similar, there were higher risk of thrombotic events in the rivaroxaban NAM. Now, newer agent, petrixaban was a factor Xa inhibitor with mainly less renal excretion, but this drug was discontinued in 2022 because of its business reason, which this is the FDA thing. Now, newer factor 11A inhibitor. We know that factor 11A deficiency causes hemophilia C or Rosenthal disease. In these people who have this factor 11A deficiency, there is no significant bleeding. They have minimal bleeding risk but less thrombotic events. So, three types of agents are being taken. The first two, antisense oligonucleotide and monoclonal antibody. These are injectable form, while the small molecule which reversibly bind to factor 11A, these are the oral anticoagulant. Melvixan and Asundexian were the two agents which have been under phase 2 trial. We have Pacific AF trial and Pacific AMA trial published last year, which is mainly dose. It's a phase 2 trial, so they're just trying to find out the correct dose. So the dose of Asundexian 20 mg and 50 mg was compared with Apixaban 5 mg BD. There was significantly less bleeding risk, but thrombotic events were similar. The advantage of this agent is that increasing Asundexian from 20 mg to 50 mg, there's no significant bleeding. While compared to Apixaban, there's a significant lesser bleeding event. The main reason why they say is that Asundexian acts mainly in the intrinsic pathway. So if there's a tissue injury or some damage when there's a bleeding, the extrinsic pathway and the common coagulation can happen through the extrinsic pathway and clot formation can happen with that. So these agents will have lesser bleeding, but maybe we have to wait for Oceanic, the phase 3 trial, which will be published in 2 years from now. Whether they reduce the thrombotic events or not, we'll have to wait and see. With this, I'll be ending my talk. Thank you.
Thank you. At present, warfarin is the indication for warfarin for the patients a mechanical valve, and now in antiphospholipid antibody syndrome. These are the two areas where we cannot.
And rheumatic non-valvular AF, and three indications.
Pardon?
And end-stage renal disease. ESRD also.
But ESRD patients on dialysis.
Post-gastric.
On dialysis. Otherwise, you can.
And the ESRD.
Depending upon your
EGFR less than 15
ESRD, there's a new trial on Apixaban. So Apixaban is better.
But
on
EGFR below 15, we don't have data.
The latest one trial is there.
Oh, it is.
Yeah, in Apixaban. Another thing, the other post-gastric bypass surgery, the absorption is erratic. So NOAC we can't monitor. So warfarin is still. While atrial thrombus, there is guideline that we can use NOAC, but LV thrombus still it is controversial. So warfarin is preferred. Then
sir, we have RCT, but guideline says because
it's warfarin.
Because the trials have come. This one is coming to 2023. So maybe we have a randomized control trial, and 3 major trials are there, which we'll have to wait for 2 years for the outcome to come, which may change.
Protein C, protein S deficiency, again warfarin is the drug of choice.
And among the different bands, which band is your personal choice and why?
I would prefer Apixaban because bleeding risks are lesser. There are studies comparing thing, and most of the patients are CKD. So all the other rivaroxaban, dabigatran, all of them require a modification, lesser dose when the EGFR is less than 50, and it is contraindicated when EGFR is less than 15. While Apixaban, you can go up when there's no dose modification until EGFR is less than 30. So relatively less.
Dr. Sunil, nice discussion we are generating on this.
Just
two clarifications. One is how long is really practically you are using for LV clot? Because that LV dyskinetic apex is going to remain there. It again forms nidus for thrombus. And if you look into the stroke people presenting, most of them will not have a history of ACS in the recent past. They will be just having an LV dysfunction, dyskinetic apex, and our echo most often will not be able to pick up most of the LV thrombus. They present with stroke. So the rationale of 3 months and 6 months of oral anticoagulation, is it practical? How do you go about somebody who already developed a stroke and is on follow-up?
So the reason what they say is after 3 months or 6 months, it gets organized. The clot gets organized, and from there, chance of clot is less. But as long as LV dysfunction is there or there's a disconnected segment, yes. The guideline says that you can stop for MI or ACS, you can stop after 3 months. That is the American. And for dilated cardiomyopathy, you can stop after 6 months. This is what the thing. But most of the time, neurologists, they want to continue lifelong.
Which should be okay if the bleeding risk is not high.
But this is what we don't have data. There's enough data to support that.
The choice of anticoagulation in post-transplant patients, especially post-liver transplant, what is the choice?
Post-liver transplant?
If patient is having an AF or something, because these drugs may interact with NOAC. So
No, because see, drugs which interact are, because recently had a HIV positive patient got admitted to DVT. So in that protein inhibitors, you have to reduce you have to give half dose. I'm not sure about the other drugs. I will have to verify.
I think
the European Society guidelines gives a clear thing which are the drugs which interacts with NOACs.
But majority of the drugs, I think there is an interaction with NOAC, and there are some studies which have shown rivaroxaban can be used. But otherwise, I think again vitamin K antagonist is a better choice where you can see the effect and then monitor and give it.
Does the availability of antidotes make a decision? Because the dabigatran has ready availability if you have
both have got dabigatran, and there is thing. For both, there are
the availability, I think there is a problem.
No, but the cost is, I think, the cost is 11,000 pounds. This is the cost of it. Actually, this availability, this is an issue when patients with AF comes, you have patient on Novax, come with stroke, whether you can't thrombolyze the patient. So you have to ideally reverse it and then thrombolyze. That is how the guidelines say. It's just not possible in India.
And finally, what is your opinion on the role of rivaroxaban in chronic ischemic heart disease?
We have disease. Rivaroxaban low dose has been used, but with a higher risk of bleeding. COMPASS trial. This has been addressed some time back. This is there, but it comes with a higher risk of bleeding.
Okay, thank you. We'll go on to the one more.
Yes, CB told we have few patients with unprovoked venous thromboembolism, where their thrombophilia profile didn't show any protein C or protein S efficiency. These patients were put on DOACs, but they came back with recurrent. So any experience like unprovoked DVT, we feel that it's better to continue on oral anticoagulants. But even if their thrombophilia profile is normal,
now the distinction, the newer Braunwald also, there's no much distinction between provoked and unprovoked. That has gone off. So there are reports that one anticoagulation fails, you switch over to other. And people who are resistant to Novax, maybe you can give warfarin, it will be an alternate.
Thank you, sir. Sorry to interrupt.
We'll move on to the next topic, glycemic control by CB Isaac.
My talk is on glycemic control in CHIP interventions. I was given 5 minutes. I'll try to extend to 7 minutes. With or without diabetes, critically ill or non-critically ill patients, non-controversial finding from various studies, strong association between hyperglycemia and clinical outcomes, because hyperglycemia leads to oxidative stress, endothelial cell dysfunction, platelet dysfunction, vascular smooth muscle proliferation, and inflammation. In hyperglycemia, more incidence of intra-procedural and post-procedural stent-related complications like stent thrombosis, intra-stent restenosis, and neoatherosclerosis. And studies have shown that peri-procedural glycemic control, 50% decrease in the incidence of in-stent restenosis at 6 months follow-up. And in sick patients, the target glucose level is 140 to 180 milligram per deciliter. And initiate the therapy when blood glucose level is more than 180. And glucose target as low as less than 110 is not recommended because of the risk of hypoglycemia. Next question is whether it should be intensive glycemic therapy or conventional glucose control. NICE sugar study in critically ill patients without myocardial infarction has shown that increased mortality at 3 months in the intensive arm. Similar result in ACCORD trial, and meta-analysis of 26 trials, including ADVANCE and VADT trials, intensive arm there is no mortality benefit. However, in the UK PDS trial, in young patients, long-term follow-up more than 10 years, there is decreased risk of macrovascular complication, including myocardial infarction. So we can conclude that in younger patients, the intensive therapy with a HbA1c less than 7% may be ideal, while in elderly and CRF patients, sick patients, less intensive control with HbA1c around 8%. Management of hyperglycemia in the intensive care unit, insulin is the best for critically ill patients. And intravenous infusion of short-acting insulin is preferred because you have control over your, depending on the blood sugar level, we can adjust it. In the acute peri-infarct period, glucose insulin potassium infusion has been studied, but neutral effect on mortality no longer used. And DIGAMI trials in acute MI with insulin glucose infusion. DIGAMI 1 trial, there was benefit with insulin, but it was 600 odd patients, small number, it's underpowered. So DIGAMI 2 trial, there were 3 groups, insulin glucose followed by insulin therapy for 3 months, then insulin glucose followed by oral hypoglycemic agents and routine metabolic management. The results was glucose control was similar with no mortality difference. So practically we use insulin in the peri-acute infarct period where patient has that stress-induced hyperglycemia, and later before discharge we can change to oral hypoglycemic agents. Management of hyperglycemia in the non-ICU setting, the popular method is sliding scale insulin therapy, but it is not acceptable because it results in undesirable levels of hypoglycemia as well as hyperglycemia. The more physiological approach is subcutaneous basal bolus therapy, that is basal insulin for once daily and bolus therapy during the meals 3 times daily. In mild elevations, once daily subcutaneous basal therapy even may be given, and similar results were obtained with basal plus therapy, that is basal insulin plus oral hypoglycemic agents. Non-insulin agents for glycemic control, we can divide into 3 groups, those with mortality benefit and weight loss. Both another group is there is mortality benefit but weight neutral. Third group is there is weight gain. And those with mortality benefit in CV outcome trial, 2 agents, GLP-1 agonists and SGLT2 inhibitors. GLP-1 agonists are direct beneficial cardiac and vascular action beyond the glycemic control. We have various CV outcome trials in liraglutide, albiglutide, various molecules. All of them showed cardiovascular benefits. And among them, Pioneer 6 trial with oral semaglutide is very appealing. So we are using oral semaglutide. It decreased the major adverse coronary events, instant restenosis, mortality, heart failure, and improved clinical outcomes. Potential adverse effects include nausea and diarrhea. SGLT2 inhibitors, in all the trials, there is decreased heart failure, hospitalization, decreased mortality. Dr. Nadarajan will be talking in detail about SGLT2 inhibitors. And the second group of agents are cardiac safe agents with no weight gain. They include DPP4 inhibitors and metformin. DPP4 inhibitors are known to prevent the plaque progression, decrease stent thrombosis, and decrease instant restenosis. They are cardiac safe, but there are no cardiovascular outcome data. Saxagliptin, allogliptin should be avoided in heart failure. Potential adverse effects include nasopharyngitis and headache. And acute coronary syndrome Israeli survey has shown that sitagliptin is associated with a decrease in hospital complication and decreased 30-day major adverse coronary events. And there are even animal studies with the vildagliptin eluting stents, which shows that better arterial healing and decreased vascular smooth muscle hyperplasia. So DPP4 inhibitors are good agents for control. And metformin is, as we know, it's an insulin sensitizer, no hypoglycemia. It decreased the platelet activation, decreased mortality. There is CV outcome data, UKPDS and home study, and it's a weight neutral agent and can be given in compensated heart failure as well as mild kidney disease patient. Adverse effects include gastritis and lactic acidosis in renal failure. So it is better to discontinue metformin 48 hours prior to PCI in those with decreased renal function. And oral hypoglycemic agents with potential weight gain effect include sulfonyl ureas. They are potent drugs, but risk of hypoglycemia. Elderly agents should be careful. Newer agents like glimepiride and glycosides are preferred. In Carolina trial, it was sulfonyl ureas compared with linagliptin. They found that the MACE rates are equal. So we can consider this a final add-on drug to other agents like SGLT2 inhibitors or DPP4 inhibitors. Thiazolidinediones like pioglitazone, anti-atherosclerotic effect is there, decreased ISR and target vessel revascularization, control both fasting and postprandial glucose. It's an insulin sensitizer. It can lead to fluid retention, so try to avoid in heart failure. Thank you.
There are a lot of trials initially with the ischemic preconditioning and liraglutide. And now that we have a semaglutide, now I don't know whether the free availability of the semaglutide. Sometimes the supply is also less. So in your
Oral semaglutide is available. We are regularly using.
Sometimes the stocks are not as easy as availability.
But per month cost is 10,000 rupees.
10,000 rupees.
And should be taken with in very early morning with half glass of water, lot of.
And it is a weight gain, reduction of the weight gain.
Definitely there is reduction in the weight gain.
And other than that,
I think SGLT2 inhibitors have become a cardiologist molecule rather than a endocrinology molecule.
The next talk is on that.
Yes.
Very important topic as long as the long-term outcome of the patient is concerned. And most often, I think every cardiologist will be very comfortable with SGLT2 inhibitors, gliptins. As you told, if it is not controlling, then put glimepiride or something, and then add a basal bolus. Till that time, we will be managing. And then, if multiple dose of insulin, then he goes to the endocrinology side or otherwise. And otherwise, most of us are very happy getting an HbA1c of 7.2, 7.3. But then, as you told, if somebody with an elderly patient, you don't mind them going to 8. And the UKPDS trial was type 1 diabetes, type 1, that younger population having some benefit on stricter control was a type 1 population. So overall, yes, sugars, we need to tackle more often our own patients rather than sending to endocrinologists. So this topic is very important for us.
Stable CHIP patients, I think we can continue the patient's drugs. And only if they destabilize, we can add some short-acting insulin.
in your clinical practice, do you omit metformin in all in patients with mild renal dysfunction?
That is a
Prior to the
guideline.
angiogram, as per the guideline, it is true. But
Yeah.
do you practice that?
In elective cases, I try to withhold in renal failure patients. In renal failure patients, I try to, because of dye-induced nephropathy risk, then reintroduce after it. Otherwise, in regular patients, no guideline.
Thank you.
I invite Dr. Natarajan for the next talk.
When this session started, Dr. Anil was actually sitting in a leaning posture. Then he actually sat erect. Now he's actually standing. So in the next 5 minutes, we'll quickly go through the role of SGLT2 inhibitor, whether it is CHIP intervention or non-CHIP intervention. Having a patient stable with heart failure with adequate pre-treatment is very essential to improve procedural as well as post-procedural outcomes. We'll quickly go through the magnitude of the problem of heart failure, the guidelines, the important role of SGLT2 inhibition in heart failure management, the safety of these agents in very large subsets of patient profiles, the role of dapagliflozin in heart failure CKD, early institution of the 4 foundational drugs in comparison to the age-old one by one sequential addition of these drugs, and a word of caution about generics. Heart failure is a growing public problem, as we all know. It increases hospitalization, mortality. Heart failure hospitalization is projected to rise by 50% over the next 25 years, and mortality significantly increases with each hospital readmission. And it starts as an insidious disease from stage A with only risk factors, then goes on to stage B, relentless progression to stage C, as well as stage D. Despite the poor prognosis, there is a delay in early detection of this problem and initiation of guideline-directed medical therapy. What about the guidelines? Very clearly, the 4 foundational drugs are drugs acting on the renin-angiotensin system, mineralocorticoid receptor antagonists, SGLT2 inhibition, and loop diuretics for fluid retention. And based on other lesion subsets, for example, prolonged QRS interval in patients with severe LV dysfunction, they become candidates for CRT. But the bottom line is these are the important drugs, the foundational drugs in the treatment of heart failure, according to the ESC guidelines, as well as according to the American guidelines of 2022. SGLT2 inhibition, beta blocker, MRA, ARNI are the 4 foundational drugs, and SGLT2 has a class 1A indication. This is a busy slide. If you go through all the subsets of patients with heart failure, whether they have heart rate more than 70, less than 70, whether their BP is more than 90, less than 90, whether they have CKD, whether they have hyperkalemia, in all subsets of patients, SGLT2 inhibition can be safely considered. Whereas drugs like, for example, if there is hyperkalemia, you cannot give MRA. When there is profound renal impairment, you cannot give ARNI. Whereas all subsets of patients, it is reasonably safe to consider SGLT2 inhibition. A few of the trial evidences, the DAPA heart failure trial as against the DECLARE trial. This was predominantly a heart failure trial. It enrolled both patients with diabetes and those without diabetes mellitus. About 4,700 patients were randomized, and these were the inclusion criteria. And the primary endpoint was a composite of cardiovascular death, worsening heart failure, or urgent heart failure visit to the hospital. So these were the primary endpoints. And if you see, there is a significant benefit of dapagliflozin over placebo, with the benefit starting as early as the first month of randomization, with a 26% relative risk reduction of the composite endpoint, and reduction in cardiovascular death as well as worsening heart failure. And whether it is diabetic or non-diabetic, the benefits were still preserved. So diabetes or non-diabetes did not have an impact on the benefit, and it was well tolerated, even in those patients without type 2 diabetes, without the risk of hypoglycemia. And in contrast to empagliflozin, which was tried in the Emperor reduced trial, cardiovascular death and all-cause death reduction was more substantial with dapagliflozin in comparison to empagliflozin. They were not one-to-one comparison, indirect comparison based on their individual trials. What about patients with CKD or at risk for CKD? All of us should understand that kidney failure and heart failure, they are twins because of shared risk factors. So this trial, the DAPA CKD trial, like the DAPA heart failure trial, which tried this molecule in heart failure, this was done in patients who are at risk for CKD, and the primary endpoint was a composite sustained more than or equal to 50% eGFR decline, end-stage kidney disease, renal, and also cardiovascular death. And all endpoints were substantially different in favor of dapagliflozin as compared to placebo. Whether it's a composite endpoint, all-cause mortality, renal outcomes, as well as cardiovascular outcomes, heart failure outcomes, all were so substantially better with dapagliflozin that this trial was stopped prematurely. And whether the patient had a heart failure, clinical heart failure or no heart failure, whether they had diabetes or no diabetes, the differences were persistent. And again, in terms of all-cause death and composite of cardiovascular death and heart failure hospitalization, dapagliflozin was even better than empagliflozin in the EMPA kidney study. Again, these were not one-to-one comparisons. Now coming to the last point, traditionally these molecules, the 4 foundational drugs, were sequentially added. And now we know that we have to give them together or as quickly as possible over a period of 4 weeks. This is a cross-trial analysis of indirect comparisons of the Emphasis Heart Failure Trial, the DAPA Heart Failure Trial, and the Paradigm Heart Failure Trial, which was published 3 years back in Lancet. So if a patient is given conventional therapy, you can see the green curves, conventional therapy with ACE inhibitor, ARB plus beta blocker, as against the 4 foundational drugs, that is ARNI, beta blocker, MRN, SGLT2 inhibition. If given for a patient of 65 years of age, you have an advantage of 6.3 years improvement in the survival. This is not a randomized trial. This is just an arithmetic study with cross-trial analysis of existing data from the 4 landmark trials. This is with regards to the sequential addition. Previously, we used to start these patients on ACE inhibitor, then on beta blocker, then on MRA, then on ARNI, and the step 5 is SGLT2. A significant time is wasted. About 6 months is wasted by this sequential addition. So now we know that we don't have to do the sequential addition. We can start them much earlier. You can give a combination of beta blocker, SGLT2 inhibition as a first step. And within 4 weeks period, you can give all the 4 foundational drugs going by this arithmetic model. And lastly, a word of caution about the generic model, generic equivalence. Pharmacological equivalence is not equal to bioequivalence, and bioequivalence is not equal to therapeutic equivalence. We have a lot of randomized controlled trials with a wealth of information in the original innovator molecule, which we don't have with the generic model, which we have to keep in mind, though we have the cost concerns. And this has been shown in the statin trials as well as in trials like clopidogrel. Lastly, in summary, SGLT2 inhibition, including dapagliflozin, is recommended in patients with heart failure with reduced ejection fraction. GDMT includes dapagliflozin as one of the 4 foundational drugs, and this effect has been demonstrated both in the DAPA heart failure trial as well as in the DAPA CKD trial. And lastly, bioequivalence and therapeutic equivalence are points to be considered when you venture on giving these patients generic equivalence of the original innovator molecule, because you don't have the evidence in favor of the generic versions. Thank you for your kind attention.
Thank you, Dr. Natarajan. Crisp presentation. Natarajan, one thing is that in many of the trials in the congestive heart failure experimental with Victoria trial or even the Paradigm trial, the use of SGL2 is not much. They all trial is not taken into consideration of the SGL2. That time the DAPA heart failure trial was not there. So in fact, DAPA heart failure trial is where we don't have much trials where SGL2 also included, like the whole pillars. Like then another thing is that when you mention the dapagliflozin and empagliflozin, one place where empagliflozin is found to be a little more useful than the DAPA is when the EGFR is almost to the 15. Yeah. Whereas in DAPA is found to be useful only up to 30, not used beyond that. And what's your opinion about that? Whether can we use DAPA till EGFR of around 15, or do we have any evidence to talk about it?
See, that you're talking about the trial. The inclusion criteria of these 2 trials was like that. But currently we have the practice pattern suggests that you can give dapagliflozin up to a EGFR of 15. It is safe. But as you said, the trial was, the inclusion criteria of these 2 trials was different. Yeah.
So now that a lot of combinations are available in practice, do you like to prescribe the combinations of SGLT2 with metformin or the DPP4? A lot of combinations are available in the market. And number 2, if you are sending these patients for a cardiac surgery or a non-cardiac surgery, do you insist on stopping them? And how common have you seen or heard about this euglycemic ketosis?
Though it is one of the cautions with this molecule, I don't know how much it is practically relevant. If you maintain adequate hydration, you should not worry about this particular event. And this combination pills is particularly relevant for a country like India. And we now have this polypill concept. In fact, India is going to be one of the enrolling centers for a polypill trial which is coming up. It is purely a question of economics. There is no such trial as to combination versus no combination. It's reasonable to consider these combination therapy in particularly countries like India where cost benefits are there.
Euglycemic ketosis is a reality. In fact, we had a few patients in that state. Then another thing is that one thing which we have to be very careful is the urinary tract infections, especially with the SGL2 inhibitors in elderly age group ladies. Many patients do report with recurrent urinary tract infections and sometimes with hyponatremia too, because of diuretics, as well as this thing can produce osmotic diuresis. All this can produce hyponatremia. Two things which we need to be look into is one is recurrent infections and next is this. If the patient develops recurrent infection, definitely we have to stop it.
Our endocrinologists don't start when patients are acutely sick.
That's right.
Whereas we are told now to start at the earliest. So in fact, I have started in instances where even our endocrinologist has said not to start. What is your thought on taking in on an
No, I agree with you. The endocrinologist is more concerned about that particular thing. As cardiologists, we are not. But cardiologists, in patients who are not very sick, not class 4 patients, those who are ambulant heart failure, you should have a lower threshold to start these molecules and hike up to the 4 foundational drugs as early as possible. Of course, taking into cognizance what points have already been raised, this euglycemic ketoacidosis, which is not quite common in cardiac practice. Maybe we are under diagnosing such complications. In our experience, it's quite rare, isn't it?
We'll move ahead with the
SGLT2 inhibitor probably is a cardiology molecule. I just wanted, and this was a nice talk, I was just wanted to emphasize a point. There was an article by Eugene Braunwald in European Heart Journal. He was telling that it is the statin of 21st century.
They're suggesting that we might even add in the drinking water soon.
Can we move on, sir?
Chairpersons are quite reluctant, no?
Thank you, Dr. Natarajan. We have a presentation by Dr. Mihas Kodanjeri, the one we missed yesterday. CHIP with limited on-site cardiac surgery backup. This is a video that will be coming up.
And followed by the chip in a box case. Actually, yesterday we were fighting against the live case. Today we are fighting against the World Cup. But Dr. Mihas was very nice to postpone his talk for today. We call the chairpersons, we can call them onto the stage. No, it's okay. No. Dr. Pratap, NIC, the chair of NIC, welcome to CHIP 2023.
Dr. Anand.
And we have Dr. Anand Kumar, Dr. C.B. Isaac. Please occupy the chair. We have a very interesting talk followed by a chip in the box. Dr. Anand.
Dr. Anand and Dr. C.B. Isaac, please.
CB, come. Have great company on the stage.
Mihas, can you start?
You are muted.
Mihas, you are muted, and can you start?
Can you hear me now?
Yes, loud and clear.
Okay, thank you. Can you see my screen?
Yes.
Can you go into the full screen?
Good morning, everyone. I want to thank Aster as well as the organizers for giving me this chance. And I want to thank Dr. Pratap for being the panelist. It's a little bit being nervous to present in front of you and also about something that is very dear to you. So I work in a 600-bed hospital. There is a tendency for in United States to have a severe shortage of cardiothoracic surgeons because of the increased skills of interventional cardiologists and structural cardiology. In a hospital of 600 beds, we have one cardiothoracic surgeon who is covering about 30 days. So this problem started and got worse during the COVID era. And I'm going to share my experience in our hospital where we had to step up and give a lot of high-risk intervention to people with triple vessel disease because of the lack of resources. The only disclosure I have is that I'm a consultant and a proctor for Abiomed, which makes the Impella. These are the three pyramids of the high-risk interventions. So we started by doing the coronary artery disease heart team, where 2 interventional cardiologists and the cardiac surgeon had to agree that CHIP is the best strategy to go. The patient and a family member had to take the responsibility, and we didn't need a cardiothoracic surgeon on site whenever we were doing the CHIP. I'm going to first present the data from my hospital, which we presented in TCT, about the feasibility of doing CHIP with limited on-site backup surgery. And we included all the cases that was done from June of 2019 to present. And I presented 120 cases with 2-year follow-up in the TCT this year. We used the SCAI PCI calculator, syntax, and STS score to assess what is the risk that the patient is facing by going to the CHIP. We recorded the medical comorbidities, technical aspects of the complex PCI, and the approaches that we did in the cath lab. We also documented the need for mechanical circulatory support, and these were all shared with the patient. This is the score that we used for detecting if a mechanical circulatory support is needed or not. And whenever the score was more than 3, we used either balloon pump or Impella. Most of our cases were, however, Impella. We used the SCAI calculator to calculate the predicted mortality, blood transfusion, and the risk of contractile nephropathy. And we used the E-CABG score, which comes from the latest guideline from SCAI about how to use surgical resources in CHIP. And this calculator will actually give you the risk of emergency CABG during CHIP to low, moderate, or high. And if it is low or moderate, we never involve the surgeon. If it was high, we made the surgeon available and we wouldn't let him scrub into a case when we are doing the CHIP. This score, however, still overestimates the risk of emergency CABG during surgery, because even in high-risk patients, the risk was only about 0.6%. We had extremes of age, very unfavorable BMIs. About 70% of patients had heart failure exacerbation within the last 2 weeks. About 60% of patients had class 3, class 4 heart failure. Majority of our patients were elective. The most common presentation was unstable angina followed by STEMI. We had good optimal medical management prior to the intervention in around 80% of cases. 2/3 of the patients had a very high syntax score, and we used atherectomy in around 70% of cases. We also fed the information to the STS database, and the average mortality if these patients had gone for surgery was around 8%. The most common cause for CABG turn down was high mortality and morbidity associated with CABG, and second was poorly controlled comorbidities. As I said, the most common atherectomy that we used was orbital atherectomy. We used lithotripsy around 40%. Our IVUS intravascular imaging has to improve. Our radial interventions also had to improve, and there was very low use of radial because most of the time the intervention was done through a 7 French sheath. The most common complication we had in the cath lab was no reflow, followed by inability to wean the Impella in the cath lab. Our vascular complication rate was very low. Of the 120 patients, only 1 patient needed a vascular surgery as a complication of dissection and acute vessel closure. We had no on-table death. Our 30-day mortality was around 1.6%. Our 1-year mortality was 8%. And I want to highlight the optimum registry where the 30-day mortality was around 8%. We also looked at the morbidity data. Our heart failure admissions in 30 days was only 0.8%. Our 1-year ACS related to the revascularization was 1.6%. Our instant restenosis was 1.6%. Our target vessel revascularization was only 1.6% over 2 years. We did not have any stent thrombosis. Our ischemic stroke was 1.6%, and we had no intracranial bleed. So we concluded that from our retrospective data that in a situation where the resources are restricted and patients have limited acceptability to surgery, complex high-risk intervention with the mechanical circulatory support is a viable option in patients who have a STS calculated mortality of more than 3%. I wanted to go through a few of the prototype cases. This is a lady who came with an NSTEMI and left main with severe peripheral vascular disease. And this was how the left main was. We went into the provisional stenting strategy, shockwave the LAD and circumflex, and this was our outcome. This was a 67-year-old lady who came with an NSTEMI and abdominal pain, and her abdominal pain was from an impending saccular aneurysm, which had an impending rupture based on the CT. So we did an EVAR, kept the patient in the ICU for 2 days on heparin and agrostat, and took an Impella through the AFX stent, and we were able to complete the intervention. These are some complications we had. This is a large iliac artery perforation, which was treated with a covered stent. This is a perforation as a complication of CSI, the orbital atherectomy. This is the most dangerous complication I've had, where I did an orbital atherectomy in a tortuous circumflex, and you can see that I lost the burr in the vessel. Fortunately, I was able to put a second wire through, shockwave the vessel, both proximal and distal. And when I did that, the burr actually moved. And there is an interface between the wire of the Viper wire of the orbital atherectomy, which goes from 009 to 014. So I was able to lock the burr between a fine cross and the wire interface and pull it out. And then we completed the case by direct stenting. Sorry, I had to rush through. I only had a small amount of time. And thank you for the attention, and I'm happy to take any questions.
Mohan, it was a wonderful talk. I just wanted to ask you that all the cases of chip cases, the defined chip cases by you use MCS or not? All the cases? Or will you do some of the cases without a mechanical circulatory support? Because there is a debate that I have to do a debate today. The debate actually, I should tell people that MCS is not required. You are telling every case you use an MCS, you know. The opponent is actually smiling at me. So I wanted to ask, get your opinion about that.
No, that is not true. The data that I presented in the TCT was the data that I showed here. And the 120 patients where the chip was done with MCS in a community hospital was the one that I presented. All the chip cases were not with MCS, but the data that I presented was the one with MCS, because that was the registry that we maintained. I showed you the Impella score, which we had designed in collaboration with the University of Washington. And whenever the score was more than 3 was when we used mechanical circulatory support. So I would say that in the chips that was being done, 2 out of 3 were the ones which had a high score, and we used mechanical circulatory support. Now, I have the largest experience of large bore access in my hospitals, and we have a group of 16 interventional cardiologists, and the ones that have a large bore gets funneled through me. So my experience is more with the ones that a large bore is used. So there is significant number of other high risk chip cases that's going on the hospital in which I don't get involved. And that data was not involved, and that was not recorded in the presentation that I made here today.
So what is the most common type of MCS you are using? Is it Impella or IABP? Is Impella covered under your insurance schemes? Because yesterday Dr. Ajit was presenting in, they are using a lot of IABP still nowadays. So what is your type of practice?
Yeah, I mean, I would say that it's a 1:2 ratio. The cardiologists who are more comfortable with large bore access tends to use more Impellas. Who are uncomfortable with large bore access tends to use the 7 French or the 8 French balloon pump. As far as the insurance coverage is, the biggest difficulty we have is in the administration agreeing to start an Impella program. Once the program is started, the reimbursement is actually very good. The biggest problem with using a Impella assisted intervention is that the reimbursement from Medicare is about $100,000 for this intervention. The cost of this this device is around $20,000. So the hospital makes a humongous amount of money from this. The physician doesn't, by the way. So the problem is that because of that, we come under the microscope when we start doing it. And if your mortality goes above 3%, then you're at very high risk of audited, denied payment next year.
Mihas, can we move on to the live in a box? You have 20 minutes for that.
Sure.
Okay. Live in a box.
You please show the live in box. That is more interested by the people.
All right, I'm going to
We are seeing a slide.
can you see the slide?
Yes, yes, yes.
So I want to present a 74-year-old with a BMI of 27, poorly controlled diabetes mellitus or oral therapy, severe chronic lung disease, presented with NSTEMI and heart failure with normal EF. She had NYHA class 4 angina. This was the SCAI PCI calculated mortality. The syntax score was around 50, and her cabbage and PCI mortality is given here. And when we fed the data into the syntax, the treatment recommendation was cabbage. This was the STS database. Her operating mortality on the STS database was around 18%. And this was her Impella score, which was around 5. This is the angiogram. It was almost like a trifurcation disease where was a large...
No, we cannot see the... okay. Actually, angiogram is not seen so far. Okay.
You cannot see the angiogram?
No. Only the slide is showing.
Slide. Next
only the
slide.
database.
Next.
Impella score has come up. The next one.
Yeah. Okay. Now show the angiogram. Now we can see the angiogram, but your sound...
Not running.
It's only an image or it is running? Okay.
No, it's playing on my end.
Yeah. The right hand image is playing, the left is not. LCA is not seen.
Can you see it now?
No, not the LCA, only RCA is running.
Okay, hold
yes.
on. Let me cut my video. That might be a problem.
No, it is well seen now.
You
can go to the... Now we have seen the angiogram, both the left and right. Okay.
Can we start the video here?
Yes.
Video.
Good morning, everybody. I'm Dr. Shah. I'm the cath lab director here at Methodist. Dr. Kodencher is our primary operator. We have Cami.
Yeah.
So we have a 74-year-old.
You'll have to mute the video there.
Yeah, we have muted.
Okay, good. So this is the Methodist Hospital cath lab. The person who was initially talking is Dr. Shah. He's my senior partner and the director of the cath lab. I'm the person in the black mask. And Cami is our cath lab tech. The patient is already anesthetized, intubated. It was a decision that was made based on the clinical history and the fact that she had severe COPD.
Whenever you want the video to move forward, tell us. We'll move it forward.
You can move forward. Yeah, so now we have the sheets that are required. It is our practice to get all 4 sheets, and we get bilateral femoral, arterial, and venous access. We get a 7-front arterial access on the right side. Can you pause for a second? So we get arterial access, 7-front arterial access on the right side. and an 8 French arterial axis on the left side for the impella and bilateral 6 French axis. The closure device that we use is the MANTA, and the step that we are seeing here is the MANTA step, where a MANTA measuring stick is inserted into the common femoral artery and withdrawn to measure the depth of the artery, and that is an integral step when we close the device later. You can continue. And we use a combination of both ultrasound, femoral, and marking of the femoral head under fluoroscopy to get access. Now, Dr. Shah is actually opening the Impella device. Then it actually comes in with 2 packets. The first packet has all the sheets, and the second packet is the one that has the Impella device. And the Impella comes with 2 sheets. One sheath is the short sheath, which is the 25 centimeter, and the other one is a 12 centimeter. And we usually first get access into the LV with a regular wire, and then exchange it for an Amplatz wire, and the 14 French sheath is inserted over it. Dr. Shah is showing the pigtail, and you can see there is a red tube through which the Impella wire, which is a 025 step wire, is inserted. And once the Impella catheter is in the left ventricle and right position, you take the wire out. Now, as you can see, the Impella is ramping up. Now, in this patient, the LVEDP was only 12. And you can see that because of that, the augmentation was somewhere around to 2 to 2.2. And this is some of the things that we see in the cath lab when we start the case, is that when the patient is hemodynamically stable, the blood pressures are good, the augmentation is not very good. So in some of these people, if they are stable, we leave them alone. In some of these people, we give them hydration to increase the LVEDP. Now the EBU, 7 French EBU without side hole 3.5 is engaged. One of the things that is important is that there is always a side towards which the Impella catheter is deviated depending upon the eccentricity of the aortic opening. And if the catheter goes through one side of it, it will engage properly, the other one it won't. And as you can see, the angiogram is almost a trifurcation lesion, it's a 0-1-1. Now in this anatomy, we decided to go with a V-stenting strategy. Our plan was to first wire the circumflex and then take care of the LAD next, because we thought that it was more difficult to take care of the circumflex. The Fielder FC is our workhorse wire. Now you can see that there was a double bend that was used, and it goes to the middle and then it forms a loop. We used a teleport support catheter to straighten the loop, and then we wired it all the way down. Now, based on the anatomy and the difficulty wiring, we came to the conclusion that it was futile to try to image it because IVUS would not pass. So we decided to go ahead and exchange it for the Viper wire and use the orbital atherectomy. And now the Viper wire is inserted. Can you switch the sound on for a second?
Sir, one question. In the circumflex, where are you planning to put the stent, to the major OM or to the main circ?
We are planning to do the main circ. We are planning to jail the OM. So because it's an osteal disease, one of the things that we try to do, and especially if it is tortuous, is to put the knob of the orbital atherectomy device in the middle, go forward in a glide assist mode, and then atherectomize retrograde. That reduces your chance of dissection and perforation that can happen from the tortuosity. Another problem that we have had is that anterograde atherectomy, sometimes in an ostium, is a problem for the orbital device. It's probably safer to use rod ablator. In this case, we felt that the rod ablator would not go through because it was a long segment lesion and heavily tortuous. And our comfort level with orbital atherectomy is much higher. Now you can see that I'm switching on the Dynaglide, which helps you to go inside. And we tried to move forward with the Dynaglide and it would not go through. So we decided to move the knob backwards and then decided to go ahead and atherectomize forwards. Can you switch the sound on for a second?
It's coming on.
Okay. So, you can see that it jumped. It is one of the things that at least in the early part of the
10.
Usually when, you can switch it off. Usually we do 30-second runs, and because of the tortuosity and the heaviness of the calcium, it is jumping antrograde. This is something for all practical purposes should be avoided. We did 2 runs with low speed.
Is it that bend there is more chance of rotablation having a perforation while orbital has less chance of perforation? Was it one factor guiding you to select orbital over rotablation?
No, actually when the tortuosity is higher and in circumflex, there is some evidence suggesting that rotablator is actually safer than orbital atherectomy. The reason I chose this was because it was calcified and it was a long segment lesion. I was more worried that the burr would get stuck. And my experience is also a factor. I do probably 9 orbital atherectomy for every 1 rod ablator atherectomy because of the ability to increase the lumen by adjusting the speed. And there is also a financial reason for it is from a hospital standpoint, if you have to use an atherectomy device and an IVL, the payment is the same. So if I keep using it, I'll get into trouble with the hospital.
Do we move a little faster on the video?
Yes, so now what we are doing is that we are advancing the teleport and then putting an Ironman wire in. And the next step is to advance the guide liner and put an intravascular lithotripsy in. We used a 3/12. We do not have the longer balloon that you have. Now you can see that we were using the balloon tracking technique. You'll have to stop for a second. Actually, we forwarded too much.
Go back a bit.
So we were using the balloon tracking technique where the guide liner is advanced over the balloon. There are 2 techniques that is described. One is called the inchworming and the other is called the balloon tracking. In the balloon tracking, we inflate the balloon distal to the guide liner. Now you can see that the ostium of the ostium of the circumflex is already stented. In the balloon tracking, we inflate the balloon at 2 atmospheres distal to the guide liner, and then as it's being deflated, you advance the guide liner over it. In the inchworming technique, you keep half of the balloon outside the guide liner and half inside the guide liner. You inflate it to around 6 atmospheres and deflate. And the theory is that the vacuum that creates by the deflating balloon will pull the guide liner forward. This has helped us a lot in advancing in difficult situations. Now we can see that the LAD is being wired and we tried to IVUS it. The IVUS stopped in the proximal LAD and would not go any further. And the IVUS image shows that there was 4-quadrant calcium and the left main had a good lumen without any significant stenosis, but it would not advance any more than the ostium of the LAD. So we decided to abort the technique of shockwave and decided to just exchange it for a Viper wire and go with orbital atherectomy of the LAD.
let us know when you wanted it forward.
Sure. So we went in with the shockwave wire first, with the shockwave balloon first, and we were not able to go. And now we can see that I'm doing orbital atherectomy of the LAD. You can forward it if you want.
I think Anil, you can go for, because now it is only orbital, then just going ahead.
Can we go forward a little bit, Mehas?
Yeah.
2
Yes.
minutes? Yeah, okay.
Yeah. So after that, we actually advanced the guideliner, exchanged it for an Ironman wire, and then stented both. And I guess this must be the final picture.
Yeah.
And then we IVAS both, the outcome was good. And a couple of things that we had at this point was, when we wired the circumflex, so now we are using the MANTA device. So we put a long J wire all the way to the ascending aorta. And we already know that the depth of the artery is 3.5 centimeters. So the MANTA device has a 14 front sheath in which is already in, and now the device is going through. It goes over
a 2 minutes.
Long J wire, and then you can forward it a little bit. And then we closed the MANTA, and this is the picture. After this, we actually exchanged the ipsilateral venous sheath with a device called as the Early Bird. Early Bird is actually a device that produces a 10-inch electromagnetic field around the groin. And the benefit is that if there is any kind of bleeding, it will start alarming. So groin checks is no longer trusted upon anymore, and it has 3 levels. Level 1, the nurse holds pressure for 10 minutes. Level 2, the nurse holds pressure for 20 minutes. Level 3, they have to hold pressure and call the physician, and the physician has to come in. On the right side, I'm closing it with a device called as a KELT. It's a stainless steel device. It has a stainless steel disc with a silastic ring. It has almost 99% closure rate without any complications.
Dr. Pratap, your comments, I think.
Yeah, actually, I just wanted to understand. You wrote a atherectomy done for the circumflex and then put a stent also before doing atherectomy on the left side into the LAD. We do a reverse way. Actually, I do atherectomy on the both vessels and then prepare the lesion, then putting the stent. Why you are doing like this? And this procedure can create some problems, because if stent strut is actually projecting into the LMC, then the device cannot go down and all. Can you just explain that?
Because my intention was not to, I underestimated the LAD. As I said, when I went into the case, I was under the impression that I would have a difficulty in taking care of the circumflex. I thought LAD was an easy lesion that I could just balloon with a non-compliant balloon and stent it. The IVAS changed all the plan. When the IVAS did not pass, then I was forced to atherectomize the LAD. That was not part of the plan initially. So my plan was to just, yes, did you hear me?
Yeah, we can hear you. Actually, the time is actually creating the problem. Thank you very much. Actually, we could have we really wanted to have a more discussion with you, but the time is not permitting us. And there is an India-Australia match today, so everybody wanted to see that also. That is why we are also in a hurry. Thank you for the wonderful case which is displayed here. Okay.
Thank you, Mehas. You have become an integral part of CHIP Summit. The next meeting also try to come live in person. Thank you.
Thank you.
Thank you, sir. May I request the chairpersons to continue, and please, sir. And may I request Dr. Anil Salim to kindly join the chairpersons. We have a presentation by Dr. Damodaran next. I'd like to invite Dr. Anil Salim, please. Back to you, sirs. Thank you.
Doctor. Good evening.
Hi.
Good morning. Good morning, Damodaran. Nice to see you. And now I welcome Dr. Damodaran, my close friend.
Thank you.
And classmate, yeah. But now he's in very high levels.
No,
And
not
Apollo Chennai. I welcome Damodaran for his.
Thank you. Thank you so much.
On.
Damodaran, he is in the highest level of hospital in
he's
Kerala.
making.
So you are in the highest level of hospital in Chennai. We are all small people sitting here to listen to both of you. Thank you. Please, Damodaran.
This is the best thing I always like from Pratap. He is always, I won't say sarcastic, he is encouraging type. So, good morning to all, and esteemed panelists, Dr. Pratap, Dr. Anand, and others. And thanks, Chip Summit and Dr. Rajshekhar for inviting me for this talk. My task is to give a talk on laser atherectomy in complex PCI. And sorry for the busy slide, the patient's history is like that. And this is a 72-year-old male with multimorbidity and now presented with ACS unstable angina. And going back to this one, he had 2006, he had a bare metal stent, then 2022, he had a bypass surgery, and 22 August, within 6 months, the limo was non-functional, so I was guided PCI, left manual AD. 2023, within 6 months, he underwent a DCB. This all underwent in some other institution. And he presented with us in this condition with the NCS. So as a case summary, multimorbid patient with 3 PCIs and non-bypass surgery. The issue is repeated revascularization failure. They have also documented once with the IVUS, that is under expansion, and recalcitrant restenosis, multiple metallic layers with a small MSA, and 1 or 2 of the main branches from the metallic layers. We have to decide the strategy also. If we put one more layer, those branches will get occluded. So we thought of doing a OCT guided ELCA, and this is the angiography. You can see this was done in the other institution 6 months before he presented to us, and you can see there is a tight lesion there. And you looking at the other this one, they have done only a non-compliant balloon, and they did applied a DCB. Even after the DCB, you can see fluoro-wise there is an under expansion. This is what we have done here at the time of presentation. Now that restenosis again happened the same site, the site where the BMS as well as the DES was there. So clearly, angiographically and fluoroscopically looking like a under expansion, but what else is there to have a recurrent restenosis? That is what we wanted to know. So then we did a OCT after a pre-dilatation before laser atherectomy. And it showed very clearly one thing, that is a lot of intrastenotic tissue, as well as you can see 2 metallic layers, 2 stent layers. The challenge here is not just to ablate the tissue within the lumen. The challenge is the tissue which is in between the stent layers has to be modified. That is very, very challenging. Even with the OPN balloon, it is not easy to do it. So we need some kind of atherectomy which can ablate the tissue and extruding the tissue through the stent threads. So we applied the, first before going for a ELCA, we just wanted to do away with the OPN. After OPN again did a check OCT, that was not satisfactory. Then we went ahead with the regular ELCA fashion, that is without using a contrast, only with the saline. But with the regular ELCA also the MSA was not adequate, so we did a contrast ELCA. Though contrast ELCA is an off-label indication, one thing you have to remember, whatever the high pressure balloon, OPN, can go up to 40 to 50 atmosphere at the rated burst pressure, whereas an IVL can go up to 50, whereas in a contrast ELCA, it can even reach up to 100 atmospheres, which is sometimes scary. The vessel may get ruptured, but the presence of 2 layers, I was comfortable that the vessel may not get ruptured, so we did a contrast ELCA, and you can see the good plaque modification, the evaporization of intrastenotic tissue, as well as you can see the layers, the 2 layers get reasonably, narrowed. The tissue between the 2 layers got reasonably narrowed. So then finally we did a PCB, paclitaxel coated balloon, and this was the final. This one you can see a reasonable adequate MSA and expansion of the vessels. So Just for the youngsters, I am just touching upon the laser is a spectrum of light in the UV range. The efficacy of laser depends on the tissue factors. And this is the contemporary console, which is easily movable from one lab to another lab and also easy to warm up. There are two catheters you have to remember, 0.9 millimeter and 1.4 millimeter. What we usually use is 0.9 because 0.9 you can go up to higher energies, up to 80, whereas with the 1.4 you can go only up to 40, 60. And the contemporary approach is you have to use a high energy even contrast for a resistant under expansion. The mechanism, you know, photochemical, thermal and photomechanical. These are the 5 principles you must remember, the 5S. The main issue is main thing is the size of the catheter should not go beyond 2/3 of the diameter, otherwise it may cause perforation. And the energy as well as the pulse repetition frequency. The most important thing, you have to do a continuous saline flush like in a rota so as to avoid excessive thermal damage. Also, the slow advancement will give more ablation rather than the fast advancement. So that also you have to keep in mind. The indication, what I usually do is only instant restenosis, almost 90% of the cases. Less than 10% may be a balloon uncrossable lesion or a thrombotic lesion. Not in every thrombotic lesion. When all other modalities fails, when there is a resistant thrombus, delayed presentation, ectatic coronaries, at times in SVG lesions also. This is the earliest study by Mehran which proved that ELCA is useful. This is the latest study by Lee et al. Euro intervention which says the ELCA is useful in modifying the peristent calcium. Whereas even the IVL cannot do in some of the patients with 2 layers of stent with the peristent calcium, whereas ELCA can do it. This is our small series published in IHR. This is the second case of stent under-expansion. You can see there is RCA with the homocoronary collaterals filling the distal segment. Main issue with this RCA was we should not do any dissection in the proximal part of the RCA, then it will close the homocoronary. We should be very careful. Then we did the usual way. I think Master Pratap is there. I don't need to explain. He was the moderator of my live case, this case in SHAPE. And this patient, we found out that we have a peristent calcium. You can see the calcium here. This was the main reason for that, and also a lot of new atherosclerosis. This is the usual way. Why we didn't use a DCB rather after an ELCA, DES in this case? There is a distal disease as well as the ELCA. After ELCA, we have to assess with OCT whether the tissue has been adequately removed. If that is not so, if there is a significant disease, then you have to put a stent. That is another indication for putting a DES after a restenosis. This is a balloon uncrossable lesion. This is a LCX OM CTO, short segment only, but bifurcation CTO. I was trying to wire the OM first. It was done. And then I dilated it, then did a ELCA in the usual fashion to remove the tissue. There was some under expansion. And then I was trying to cross the LCX, which was little cumbersome, then used a crusade microcatheter, dual lumen, then crossed it. Now the question is, challenge was to go take the 1.5 balloon into the LCX. It was cumbersome because of that. Can you please don't rush it, then otherwise no point in doing that. I will finish within 15 minutes. Okay. So then I applied laser in that LCX stud because otherwise the balloon was not going into through the stud. So then I applied some laser into that. Then the laser gave away the stud and gave some compliance of that vessel. Then I could easily pass the 2 millimeter balloon. Then ultimately we did a kind of a flower petal kind of a bifurcation stenting, putting a stent from the ostium of the LCX. And then this is the final result. I have 1 more minute. And this is the final case. Ostial LAD CTO is a native CTO. Here there was some microchannels, but still I was not very clear whether I could cause any dissection. So I went through antegrade wiring through the proximal cap. You can see the wire into the LAD using a 8 French catheter. Then did the wire, Fielder XTA as well as the Gaia. Here, after the pre-dilatation, this was due to the under expansion of the stent as well as there is a gross plaque with a lot of calcium in the osteoproximal LAD. And here, after pre-dilatation, there was a resistant, there was an area which was not dilatable in the proximal in-segment area. That is in the just before the segment, stented segment in the mid LAD. So I had to use a LCA here. The problem you can see, even after LCA with the NC, it was not yielding, so I had to go with a Wolverine, cutting balloon. You can see, this is what I have learned. When you are giving a lot of thermal damage to the vessel, after that you have to be very careful in doing any modification with a scoring or a specialty balloons. There is a large dissection and hematoma, then I have to do a kind of left mate LAD with a hybrid strategy. Hybrid strategy is the one, the proximal large vessel we have to do with the stenting, and the distal vessel we can go with the DCB. This is the final IVS. So with a reasonable MSA. So the take home is, this is one other tool wherein I can see, I have experienced in some of the patients with a resistant under expansion, with the multiple metallic layers, like the first case I have seen where there is no chances of opportunities for a redo bypass also, because the stent is up to the distal LAD, no area to graft. So in such patients, you have only one option, which is this therapy, which is the nice indication, and so that we can give some relief to the patient. Thank you so much.
Damodaran, wonderful case and all. My only one doubt, actually, if there is no LCA available in the hospital, which are the situations where LCA is absolutely necessary?
That's what the last line I told, no? The instant restenosis with multiple metallic layers where there is no option of CABG because the stents are up to the distal LAD. Already CABG failed cases. In such patients, even with the OPN or even with other high pressure devices, modification devices, it is not working out. So we
OPN is not replaceable for LCA. LCA is definitely an uncrossable lesion where OPN is actually coming in the next preparation of the lesion. Actually, when lesion is not crossed, then other options like rotablation is available. You have small balloons are available. So
no, this is mainly not for uncrossable, undilatable lesion.
Undilatable lesion.
Crossable but undilatable.
Undilatable also, you can actually do a rotablation and then do that.
Rota, there is a trial with Rota in the yesterday years. Rota has caused a lot of damage to the studs, a lot of thermal damage, and the Rota is not much advocated in ISR, though there are reports and some small studies of Rota stent ablation, but Rota is not the choice when compared to LCA.
So actually the first case you have shown, I think I was saying there is a myocardial bridge. Whatever you do, actually the patient may come back again. Then next choice.
You have to keep on, I think you have to tell that. As a
This
chairperson.
The instant drug-eluting stent restenosis after the laser. So what is your first option? It is the first time restenosis. Your first option is DCB or putting another stent.
So the drug-eluting stent, the first restenosis of
First
DES,
restenosis.
as per the consensus treatment, third group consensus treatment by DCB, what they are suggesting, if there is a single layer, go for another stent. If there is a multiple layers, then go for a DCB. This is what the consensus. But of late, there are a lot of emerging data on DCB, even for the single layer. First stent, you can go for a DCB if it is a focal one. If there is a diffuse restenosis with a good MSA, they can advise you to go for a restenting. But there are no robust data or a guideline recommendation for all these things, only consensus treatments.
Damodaran, very informative talk. Deepak here, Damodaran.
Yeah.
Damodaran, two small queries. Yeah. One, regarding this contrast lacing, what is the dilution that you take? Then regarding going upon joules as well as frequency, what all situations would you go with a high joules, high frequency, and what situations would you prefer going with a low energy, low frequency? And when you want to go for a high energy, high frequency, would you start at a lower energy, lower frequency, and then go to high energy, high frequency, or straight away go for it?
Yeah. In the instant restenosis, we have a metallic jacket. So usually I don't start with the lower energy, low frequency. Usually I'll start with the comfortable zone 60 something. Then immediately once I know the feel of the lesion, then I can go straight away with the 80 within the stented segments. And as far as you asked about the contrast LCA, initially when I started doing it, I was not very comfortable. So I used 1:1, like one part of saline, one part of contrast. That didn't work out in some of the resistant, under expansion. Then I started using full contrast, means contrast.
No dilution.
Yeah, no dilution. Yeah. And about the passes, usually they are advocating 4 to 5 passes. But in some because of the thermal damage. But in some cases, what we did, we did the LCA kept for some sitting in the console for some time to cool to get the muscle cooled off. Then again did another 4-5 passes that yielded in 2 or 3 of the patients. As Dr. Pratap is rightly mentioning, some of the cases with a resistant under expansion, we don't know what is the answer for this.
And what about failures with ELCA? What about failures with ELCA? Because we had a recent failure.
Failure means most of the trials are, the inclusion criteria, the endpoint criteria. If it is less than 20% of re-students, we can accept it. Like most of the cases.
No, your failure to either expand it or cross it in a
crossing is most of the time, it is not a major issue. But some of the cases, even after ELCA with the multiple passes, I could see some 10% or 20% under expansion. But when you compare this with the OCT criteria and other, that is fairly satisfactory. But we always want that straight line like picture. No? So some less than 10% is no.
We had a failure last week. We had a CT of LED, a long stent. It was difficult to wire.
ISR.
ISR CTO. It was difficult to cross it. At one particular area, the wire was crossing very close to the stented segment. That area, the ELCA didn't cross. Halfway through, it went in, but where the wire was very close to the stent, it didn't cross. Probably it was related to wiring problem.
So some of the cases, if the wire is not crossing, you can keep the catheter there, and even without a wire, you can do a blind ELCA so that it can modify the block around that. So that then you can take stiff wire, you can do that. Some of the cases you can do that, like wire and possible. Thank you.
Thank you, Damodaran, for an excellent presentation. Thank you.
Thank you, sir. Thank you, Dr. Damodaran, and thank you to the chairpersons. We quickly move on to the much-awaited debate. The big guns are coming out. The debate between Dr. Pratap Kumar and Dr. Hazra. May I invite the chairpersons now, Dr. Gerald Werner, Dr. Vijay Trehan, Dr. Ramakrishna Pillai, and Dr. Rajiv, please. Welcome to Dr. Trehan. Welcome to Dr. Trehan and Dr. Hazra. May I please hand over the proceedings to the moderators now? Over to you, sir. Before we begin, a gentle reminder. The hotel authorities have requested the checkout time is 12 p.m. Gentle reminder to all of you. 12 o'clock checkout time. Thank you.
Yeah. So, good morning. We will have a debate whether mechanical support is essential in CHIP, and the pro position will be presented by Dr. Hazra.
Right. MCS in CHIP, very essential for not good, best outcome. So first tactic of any debate, my school teacher said, to win a debate is to align your opponent, Dr. Pratap Kumar, to your side by humor. And first disclosure, for best outcome in CHIP, PCI needs MCS, not just good banana doctors like him. All chips are not born equal, and all operators are not as good as Dr. Pratap. There is universal definitions, but universal definitions is elusive to large extent. For example, on the right-hand side, in red color, if you have severe PAH, pulmonary arterial hypertension, complex gears like you want to use laser, rotor, orbital, or a hybrid kind of gears in left main calcium becomes very difficult to have the best outcome without having MCS on board. Even then, there are best practices rule. There has to be some rule in the game, in all games. So to have the best practice, to have the best outcome, you should look for complete revascularizations, minimize complications, local, retroperitoneal hematoma, etc. Optimize strength, quality of life, all-cause death. You may be doing a good job on left main, but the patient dies due to renal failure or sepsis. Less future device, costly device like ICD, CCM pacemaker, or LVAD, because you are giving them back a good ejection fractions, stent thrombosis, and ISR. Very often, Dr. David Warner, Dr. Trehan, and Pratap does this kind of heroic job: 3 stents, 3 vessel, 3 targets, 3 into 20 millimeter stent, 2 CTOs in one day. And these are the complexity we do in complex chip cases. As you grow old, like Pratap or Dr. David Warner or Dr. Trehan, you gather a lot of appetite for doing high-risk complex PCI. Proportionately, it increases with wisdom, skill, age, especially after you have a man like Pratap Kumar when he becomes the CSI NIC chairman. And there are different scores, to guide you, like NCD or BCI STIP score. And recently, A-SMART score, where age, sync-test score, all are important. The scores are getting better, devices are getting smarter, and is getting much more smarter with artificial intelligence. So what you have seen in the past is not going to see in next 10 years, because your thought process is also changing. So ultimate goal is to reach that island. And how do you reach there? On the left, you have a very beautiful boat, normal patients. And on the other side, you have a damaged boat, a smaller boat. And very complex situations, like you have to go to the canal and you face dolphins, sharks, the calciums, and ultimately reach there. And once you reach there, you come back happy and sleep well and watch the World Cup. And you can reach there with 2 minds, a beautiful mind that has to be essential for any cheap complex PCI. So you should be cool, it should be skilled. And if you have those kind of gears, like you can reach that island, like with the scuba diver goes there with an oxygen mask. So you can easily travel that terrain. And do not forget that it may come like out of, bolt from the blue. And if you've seen this movie, the Jaws, you need a bigger boat because shark is attacking you. So this unexpected shark attack can come in complex PCI, whether it is CTO or left main. And complete revascularization, minimum complications can be achieved with essential minimal, support like IBP or maximum support like Impella CP. So what is the rational perspective? Rethink before closing your ears and go home with Pratap Kumar's thought that all cheap MCI do not need. I agree to some extent. And when you see deaths, whatever happens in the cath lab, like Las Vegas, does not stay in cath lab. Your nurses, your technicians, your juniors, your enemies will spread this to other members of the society. So before closing your eyes and ears to this criticism, be prepared with the best so that nobody can question you. It is always better to have the seat belt, because once you have this kind of catastrophe in the field, there's no point, you will not get time to call for the help. It is not always the heart. Also, brain is important, kidney is also important. So keeping the blood pressure is live, because you can have this having good MCS. Cheap CTO PCI operators are not conducive to island living nowadays. They need help sometimes, but you always ask for the help like MCS. So how do you chase your goal in cheap PCI? You have access, knowledge, how to close, how to go in, how to come out, imaging, right heart catheter, MCS, etc. We also know that in hospital mortality, 5 years outcome increases 6 to 7 times by surgically turned down cases, poor LV, and CKD. Incomplete revascularizations 3 times, severe calcifications 72%,
And valvular heart disease like MR, severe MR, complex PCI, you have to have MCS. Right patient, right doctor like me, right strategy. And if you have more dysfunction, you need more protections. More complexity, you need more protections. There has to be enough ischemia, enough angina, unlike your revived BCS, viable myocardium, and right disease. There has to be some algorithm. You follow this algorithm. I know it when I see it, and someone else will know it when they see it. But what they see and what they know may or may not be what I see, know, and what I do. So seeing is not believing, doing is the believing. Teaching is the believing. And there are a lot of trials on the left-hand side for safety and efficacy, validations, and perhaps we are moving for class 1 recommendations with P4. P4 means protect 4, P1 means protect 1, etc. So what is the pathway? We have 2021, it is saying class 2B. In 2018, there is no mention about MCS, but I'm sure after P4, we'll have more clarity in the guideline. And MCS in CHIP PCI does reduce the risk factor. There are a lot of data there. It's not always true that all the laser, rota, CTO, all will benefit. Some will benefit, some will benefit to large extent, some may not benefit. But that doesn't stop you doing CTO, 2 CTOs, or left main PCI, CHIP PCI, complex PCI. The best way to avoid complication is not doing anything. But if you do something, if there is a complication, people will criticize you. So you can reduce the complication rate having MCS. And that's why all over the world, people have abandoned IBP and going towards LVAD. IBP is good, but IBP also does cause a problem. And in the BCI trial, there is some data that large size balloon does help. Now, if you go into the detail, the devil is there. All devices are not sent, like BCIS, P2, like you have used 2.5. You have to use at least CP, or for surgical turn down, or on the table 5.5. Primary endpoint in P2, small number of patients, 29%, not immediately after, but at 90 days, all-cause death. And there are different inclusion criteria, so you're getting smarter, taking more sick patients, very complex patients nowadays, and all over the world, like Germany, Italy, Japan. The longevity is increasing. People are all living more than 100 years. So these nanogenarians, and they have very poor reserve. You need sometimes this kind of help. So whatever it may happen, there will be some criticism. And Pratap will say, look, in revived BCS, there is no need for MCS in very sick patients. So what are these revived BCS 2 patients? Only 3% required MCS, 70 years, ejection fraction 27%, and protect 3 is 23%. And look at left main, only 14%. And NOIJ class 2 is only 23%. Abysmal number. Anyway, so let's move forward with the data, P2 data, MACE data. And Impella reduces MACE. It gives a chance for complete revascularizations. It improves the MACE. There is no doubt that death is reduced. The perioperative MI is reduced. And if you use cautiously the Clover device, your complication rate due to vascular complication now it is coming down. So bigger Impella, bigger boat, better outcome. Now this is P4, we are taking less than 30% now. Up to 30% now. In 2023, they have revised and looking for this kind of outcome. Hospitalizations, MACE, the need for costly LVAD. You may argue that this is costly. LVAD is almost 1 crore rupees in our hospital. CCM pacemaker in our hospital, 50 lakhs. So Restore HF, and there's Restore HF. If you combine these 3 trials, Restore HF, P3 data, Roma, Verona, all these trials are saying that ejection fraction improves, and lower the ejection fraction, better outcome, better ejection fraction improvement in 90 days. It improves the anginal symptoms. 99% reductions, and the kidney is also protected. So Impella for kidney, Impella for heart, Impella for your cell protection, your own skin, your own brain, and reputations. You cannot reduce the age of elderly people, but you can reduce the age, and you can always go for complete revascularizations even in elderly. Impella improves coronary perfusions. It gives a lot of time to think, to do a complex case, because there is less hemodynamic compromise. Even Gurunji could have loved it if the LAD was a single surviving artery. And that time it was not there. Suppose his ejection patients was very elderly, low ejection fraction, creatinine. And complete revascularization, improves outcome. And the syntax trial, if you have a operator in Germany versus operator in India, the outcome will be different. But once you have a complex PCI and you have MCS, even if you're a cat, you'll feel like lion. So Impella does improve this kind of complete revascularization, the percentage restored. So there is a joke, there is a mechanic. He asked the doctor that I also fix an engine and you also fix an engine. How come you earn much more than me? The doctor said, look, you fix a running engine and come back to me. The mechanic said, you also you also put the heart in rest, like op pump surgery and MCS, just like op pump surgery, put it at rest and you fix it. If you have this kind of analogy, that MCS also helps in having a complete revascularization, like op pump surgery, on pump surgery in CABG. You can go to the posterior aspect of the heart if you have op pump surgery. So there are difficult areas in the heart you can reach. There are a lot of data surgically turned down. It helps. If you are on MCS, your ICU doctor at peace, the inotrope comes down. And if you have MCS in the middle of the night, you don't get called. And you don't have to rush for the VTVA shocks like Pratap Kumar. It has to be honest operator, and it has to be earliest adoptions for MCS in most of the time. And the timing is important. Timing is important, and it's better to have this facility when the house is already not on fire. Should be adequate and free of complications. And as I said in many programs, I say it again, that if the money is not an issue, it should be there in all MCS. This is the economy data. But if you have low ejection fractions, these patients needs a device like CRT, CCM, as I mentioned. So money, Mickey, and McDonald is not for, these MCS is not for everyone. There is no beauty hidden in complex PCI. There is some ugliness, and you always look for the hidden enemies in complex PCI, because it can throw back your bomb and the patient will die. So last disclosure, I don't like it when my patient die after PCI or any PCI. I really hope that Dr. Pratap would not kill his patient this way. And postulation, like you can say that a lot, not many data, but parachute, it doesn't require a rocket science to understand that if you have difficulties, and if you really want to save your life, then the parachute does not require any RCT. Thank you.
Now, Dr. Pratap will have his say about the need for a protection for a chip patient.
Respected chairperson and my dear friend PK Hastra, I don't have photographs like him, but I have a pump, that is the pump he uses. Evolution of PCI started in 1958 with the first selective coronary angiogram. January 2020, the robotic angioplasty started. So actually the advances in technology because of anatomy, comorbidity, and equipment. Newer weapons, that is mechanical circulatory support. You look at what is Iron Dome. Basically, the Israeli people thought that they can identify everything. What is the strategy? And they did not identify. Technology fails to help sometimes. Error and system failure. What are the available devices in MCS? IABP, Impella, Tandem Heart, VA ECMO. I'm not going to details. It is purpose to reduce the LV stroke volume, to reduce the myocardial oxygen demand, to maintain the systemic and coronary perfusion and cardiac shock, to provide hemodynamic support during complex cardiac procedures. The proposed scenarios where it is useful are the high-risk PCI, cardiac arrest, acute MI with cardiac shock. What is actually high-risk PCI? These are the clinical things: low ejection fraction, coronary anatomy, LMCA, all these diseases which we do in day in, day out in our practice. What is the problem with MCS? Minimum increase of cardiac output by IABP 0.5 liter per minute. Bleeding is a major concern. Vascular complication, because IABP uses 7 to 8 French and Impella uses 13, 14, 23 French system, respectively. Maintaining a high ACT and a bigger sheath would lead to higher bleeding risk among patients with Impella. The implantation problems, you just look at the complication. Implantation-related complications, SIRS, infection-related complication, acute kidney injury, access-related complications, coronary circulatory complication, bleeding and thrombotic-related complication, ICU-related complication, from the day of implantation to the next 21 days. So these are the content. It can be used in many cases. When you have a severe AR in severe peripheral vascular disease, it cannot be used. So IABP, actually, patient uses IABP regularly, selective, or the hospital where you use IABP regularly, frequently. There is no difference in the outcome difference. In the post-MI cardiac shock IABP, no difference in mortality. If you go to the registry data, no difference in mortality or infarct size. So IABP used in acute MI in the absence of cardiac shock. No reduction in mortality, but an increased complication rate, including major bleeding and stroke in the IABP group. Use of IABP was not found to improve mortality among patients with acute MI, even in randomized controlled trials, regardless of whether patient with cardiac shock. So the acute MI did not significantly reduce the 30-day mortality. The shock trial tells. If you look at these trends in the shock 2 trials, IABP use is decreasing, but is predominantly used in sicker patients with a greater myocardium at risk. If you look at the proposed benefits of Impella in high-risk PCI, role in acute MI, role in unloading, and all these things. But if you look at the Impella versus IABP, there is definitely an advantage for Impella at 90 days, not even at 30 days. It is actually at the 90 days there is a difference, advantage for Impella. So the evolving landscape, trends in the use of Impella has steadily increased over time. But if you look at the MCS number, the MCS gone up, that is basically because of the Impella gone up, not by the, this actually IABP came down. Lower use of Impella in critically ill patients, that is the point. They use Impella in less critical patients and where there is less mechanical ventilation, less cardiac shock. Outcomes among patients with undergoing PCR receiving MCS were not any better in the Impella era. So in the Impella era, rate of death, AKI, stroke, and the cost were higher than in the pre-Impella era. So the outcomes are not better in the high-use hospitals. And the more importantly, there is a $10,000 extra money spent by these people by the use of MCS. In actually extracorporeal life support in infarct-related cardiac shock, actually the trial shows early routine ECLS was not superior to using only medical therapy. So MCS used trend from 0.2% in elective PCI to 0.6% by 9 years, but IABP use remained low and constant. IABP use associated with a higher risk of MACE and then used with the other things. So you can see that the complication rate goes up even though the MACE comes down. Actually, MCS is the last nail in the coffin. So the neither Impella nor IABP decreased all-cause mortality. Rather, Impella increased major bleeding compared with the no MCS. So the major bleeding is gone up with Impella. Guidelines telling it is even in acute MI, ACS with cardiac shock may be used, but routine usage is not recommended. ACS 2020 guidelines telling with cardiac shock without mechanical complication, your Impella usage is not recommended. If you go to the AHA guidelines, same, in selected patients may be reasonable to use, not to use. So, in high-risk PCI is defined as the professional society without elective MCS is feasible and safe in the majority of patients without elective PCI, without elective MCS, you can do this. This is actually the recommendation now. History repeats itself until we learn the lessons that we need to change our path. I'll show you some of the cases. This 65-year-old man with recurrent unstable angina, severe LV systolic dysfunction, RCA, CTO, LMCA disease with triple vessel disease. Patient had right internal carotid arteries completely occluded, left is 90%. The patient came to me, surgeon turned out case. Balloon dilated, 3 stents. You see the final result. This is the result. Patient actually had only one carotid artery with a lesion. Next day, after 3 weeks, we stented that also. This is the final outcome of the case. What is actually happening? Today, they're still on my follow-up and completed 6 years, and surgeon turned out 6 years back. Next patient, 45-year-old man, LV failure from 2016, advised transplantation because of the 24% EF, triple vessel disease. This patient had an RCA stenting, circ stenting, and LED stenting, completed 8 years and 6 months. As on today, LV ejection fraction improved to 40%, no admission so far. 58-year-old man, cabbage, triple vessel disease 8 years back with severe angina, LMC occluded. Opened, RCA circumflex opened, later on even RCA opened. This is a final result of this patient. This patient has completed 14 years. This case actually class 3 dyspnea and occluded LMCA. Even the SpO2 at room air is 86% patient. Severe COPD. Not like the case which is shown earlier as a live in box. This case, we have completed LMCA to LED done by retrograde intervention, no Impella used. 67-year-old politician, creatinine elevated from 1.8 to 2.4, ejection fraction of 22%. This was angiogram. Circ occluded, LED diffuse disease, first instance angioplasty, first angioplasty done in January 2017. Then, after that, we did angioplasty for him after 3 months because he improved. So he wanted to do everything perfect. Then after 9 months, we completed the procedure. Total duration, 7 years after PTCA and completed without any hospital stay for the last 6 years. That fellow worked with Rahul Gandhi from Trivandrum to Koilon. This is a 71-year-old left-sided chest pain with dyspnea 1 year duration. Calcified triple vessel disease, distal LMCA. See the lesion. Angiogram. I could not even tried with multiple options, single lumen catheter, double lumen catheter, IVS guided puncture, single vessel. Then I tried retrograde approach. Virus going inside. Single catheter retrograde intervention. It is done just 3 weeks back. Retrograde entry. Then rota. IVL 3x12. Into circumflex as well as to LED. And this is the final angiogram. Our story in Mediterranean column since 2015, above all cases done without MCS. I used MCS only in a live case in India Live last year, along with Manoj. We have done 496 left main intervention the last 7 years. More than 150 CTO I do in my Kollam center every year. Complex intervention another 150. No case we have done with any MCS. MCS I used only in Manipal, 2 patients and both the patients died. That is my story with Manipal. MCS is not in at all cases, at all. Factors are deciding success in interventions. Planning of the case, skill of the operator, speed by which we do the case. Devices should not be used because of industry promotion, financial advantage for the hospital, and promoting a physician on social media. Thank you, and the story will continue after intermission.
Rebuttal, please.
I think Pratap has completely misread the title. It's not cardiogenic shock debate today. Cardiogenic shock like inferior MI, distal LED, 30 years man died because of severe MR due to inferior wall microinfarction. It's not a complex PCI. Cardiogenic shock is completely different ball game. The role of Impella or ECMO or IBP still in question mark. And he said, I'm the last one to use this in, but never hang with one candle people. If you misread a debate topic, mislead you, and if you have this kind of personality like me, my MCS, I can rule the whole world and nobody can question me. So better to hang with more candle than a person with a single candle sitting here and raising your thought process to percolate in your brain that MCS do not require, cheap PCI do not require MCS. I can show you millions and millions David Warner, Tehran are doing left main without MCS because MCS was not there before 2017. So how can you talk about, how can you compare the historical construct of not having MCS with a time when you have MCS? So he has historical, I knew that he will show some cases. I also can show numbers of cases without MCS. Okay? And because sometimes you misread the title of the topic, you miscalculate the risk of the patient, the complexity of the patient, and you lose the patient. So by failing to prepare, like if you have the facilities, cost is not an issue, please use it. And it should be used like good therapy. It should not be too late when it does not work. Growth is painful, change is definitely much more painful with high cost device, but nothing is as painful as staying stuck somewhere you don't belong. So Pratap Kumar needs to learn MCS in complex PCI because he can give a better outcome, quality of life, ejection fractions to his very needy people, VIP people. So this slide, 912 Americans committed suicide, were murdered by family and friends in Guyana 1978 because of their blind obedience of not using MCS in high-risk PCI. Don't kill your patient, don't believe him, and you go by this prophet, the musician, the lyricist, Bob Dylan. How many roads must a man walk down before you call him a man? Pratap, I won't degrade him, but he's my friend. How many deaths will it take till he knows that too many people have died? The answer, my friend, is blowing in the wind, blowing with MCS. The answer is blowing in the wind. Everybody is not like Utah. You have the left main dissection, crashing CPR, then you open your MCS and you save the patient in last minute. So, coming back to the topic, essential, very much essential for good, maybe best outcome. I'm not talking about cardiogenic shock. Thank you.
You want to have a rebuttal of the rebuttal?
Rebuttal slide. Can you just go to the... Actually, PK Hastra misled. There are trials I have shown with the cardiogenic shock. All the 7 cases which I have shown, definitely, and nothing was with an ACS patient. All patients with elective PCI. So it is not that I am telling about the high-risk PCI. The documented high-risk PCI was, everything was there in that. So don't think that I misread it. I actually understood that, I have to produce some slides to show the trials where, what are the trials available, I have shown that. The story will continue after intermission. Now it is. Reasons for using NCS. I talked with an American cardiologist today. They do a simple angioplasty in the US. They will get $8,000 to the hospital. A complex angioplasty will cost $20,000. But if they use an impeller, the hospital will get $60,000. That means the hospital management is keen on having an impeller to use in a patient where impeller will give you an extra money to the organization. And that is actually one of the major reasons of using impeller in the world. And you look at, this is the data. Even the case which is shown in the live in box today, I would definitely will not use an impeller, even if an impeller is available in my hospital. Economics of the country. You should look at the economics of India. The data suggests 1% of the cases in India uses MCS. But I don't believe that, because that is a totally wrong data. Even though I presented the data, they are telling 10,000 MCS used in India. Little unbelievable. Poor people with the chip cases, definitely, do you want those people should die? They don't get a treatment? I don't know. Actually, only Ambani, Ravi Pillai and Yusuf Ali should live in this country? I don't know. All rich people are getting MCS and chip cases. And do you think that they will survive with MCS? I don't doubt. This is a case came to me. The 53-year-old man with a dyspnea on class 3, PMD for the last 3 months. He had an MI, not cardiogenic shock now. MI 7 years back, advised medical management by a doctor in Maharashtra. He's a Mallu, that's Malayali. Came to me, echo with a global LV dysfunction of 20%, mild to moderate MR, mild to moderate TR. The patient came to my hospital on a Onam celebration day. I actually attempted the case, I failed miserably, and the patient actually, I just told him, please allow me not to do this case. And this patient actually went back, and they came back again after 3 weeks. Sir, you only should do that. During my discussion in the casualty, in my OPD, he collapsed in front of me. Probably because an arrhythmia, shifted to the ICU, and then kept that. This was the situation. This patient actually having a moderate viability, advised, I told that he will land up in transplant. He told, sir, can you try something to help me for surviving for some more days, because I cannot even sleep in the night. This was the situation. I tried antegrade. You can look at the next wire, infiltrac, going totally out of the vessel. Then I crossed retrograde from the RCA. That time I had taken the left catheter out because this patient is survived only on 18% ejection fraction. Crossed. I finished with 2 stents. And he's gone back. Now minimum he is sleeping for the last 2 months. He was not sleeping for 4 months. I'm actually happy for that. That is the situation. I actually looked at my data of my hospital. I took the data by one of my fellow cardiologists. We have taken the ischemic cardiomyopathy because of the revival trial tell that always CABG is the only treatment of choice. We looked at the data from only ischemic cardiomyopathy. From January 2019 to June 2023, 40 patients. And we can see the LV ejection fraction is 30%, moderate to severe MR in almost all patients. This is the situation. LMC in 30% of the cases, triple vessel disease in 70% of the cases. We have diabetes and all these things. We have used calcium modification in nearly 13 patients. Complete revascularization was not done in some of the patients, basically because in a triple vessel disease, one CTO, we just leave it. And this is the situation. And imaging was done in 37% of the patients. Complication was only one patient had a complication that was a transient CHB and kept on TPI for 48 hours. And functional class improved in all patients. The surviving 35 patients survived even after 24 months. And that is actually only 2 patients actually have remaining on class 3 or class 4 symptoms. Median follow-up of 22 months and late mortality was 5 patients. And that is 1 is died of COVID and 2, 3, 4 people died of cardiac arrest. In conclusion, these patients actually only 1 patient had intra-op CHP. Overall observed post-PCI mortality is very less compared to their expected mortality based on their baseline syntax scoring. PCI may be considered in patients with ischemic cardiomyopathy who require revascularization but considered to be high or prohibitive risk for CABG for morbidity benefit and better survival. Thank you very much. This is my last line, and thank you very much.
Judgment time for the wise men on the stage to give their comments.
I tend personally to be a little bit in favor of Pratap's statements, because if we look at the data objectively, the data are driven by the United States. They create risk scores which have never been proven in a trial. They are just risk scores by people sitting around a table developing scores to make things complex. And when I attended the New York CTO Summit many, many years, it was about opening complex CTOs. And suddenly it becomes the CHIP CTO Summit. And the background is that in the United States there is also a legal problem. So everything that goes wrong goes to the lawyer. So if they upfront create the scenario of CHIP and discuss that and use devices to support, they are kind of out of their legal problems. And so I think for outside US, we must be sober. In my hospitals, where I do 950 PCI, we use maybe 6 or 7 impellers per year outside of the cardiac shock situation for a left dominant, left main PCI. So the overuse, I think, in US is strictly driven by legal and commercial reasons. That's my personal view on that.
Trihan, your comments.
I have it in my talk.
So in a patient, in a CHIP patient, somebody who presents with a history of cardiac.
So Mike.
Possibility of developing cardiac arrest requires protection, as everybody would agree. But as Prathapan said, the modalities that we have at the moment to protect these patients, like IABP, ECMO, or tandem heart, fall short of our expectations and demands. I agree with that. But it is hard to say that we will not use them.
So in a debate I told, but actually if you can use it, but I'm telling, for my practice, I used only one case where I think in that case, even if when I was in a live case, when he put the impeller, I told that why to use an impeller in this case? Sir, actually, this actually is supported by the impeller company also. Okay, thank you. That is what I told. I'm just telling most of the cases people use, and even today's case, morning case, the live inbox. I think, I'm telling that if anybody is sitting here, how many people would have used an impeller in that case? I think we will not use it.
And again, you need to challenge the people of these scores.
Correct.
Yeah? Also the use of the right ventricle, the right heart catheter. No doubt in cardiogenic shock, but to stratify patients who need impeller is again based on no study. Yeah, nice scores, but no study that really proves that these scores or these indexes have any prospective value. So one should be, I think, a little bit sobering about this whole thing. And as you rightly pointed out, the trials, the randomized trials, did not really show any benefit, except for the US hospital system.
We will almost never have a randomized trial. Who will pay for it? And unless I think something like WHO, many countries joining together and ready to pay for it, I don't think in the near future you're going to have a trial.
Actually, Vijay,
no trial you can have on
yesterday somebody asked Dr. Antonio Colombo why the Americans' data is not as good as the Asian population LMCA data. He told 2 points. One, Asians do imaging for improving and making the next step to improve the better stent area, better MSA and all. Number one. Number two, Asians, I should actually tell with a more slow voice, Asians are more skilled than the Americans. That is what he told yesterday openly in a forum in Gulf Independent Society. I was really shocked to hear that. And in a way, I was so happy to hear that.
We have the concluding comments.
Yeah, just one comment. See, there is no answer in a debate. It is that's why that's a debate. But then due to these conferences, our chip approach is evolving. MCS devices are evolving. So in future, this similar debates can have a different picture. So anyway, thanks to the organizers for this debate and both the speakers. Very well done. Thank you.
Last comment from my side. If you have this facility, the patients are affordable. Use it. I mean, yesterday, day before yesterday, I had a case at RC total occlusion CTO, antegrade wiring done, 5 minutes, 10 minutes. There was a long CTO in the LED, and there was a retrograde large diagonal. You know? So after putting the stent, suddenly the diagonal disappeared, and he went into complete mechanical shutdown, shock, etc. I could not save him. So losing a major side branch, he never expected that just occlusion of diagonal. So there are sometimes the unexpected. There are a lot of known, unknown. So MCS in all PCI may be unknown to some extent, but you should progress with time. Thank you.
Thank you. It was really worth midnight travel for both Prathaban and Hasra. Thank you very much. You made CHIPS 2023 memorable. Thank you.
Thank you, sir. Thank you, and congratulations to both the presenters. Move on quickly to the live chip in the box, the fifth one. May I invite the chairpersons, please? Dr. Sunil Roy, Dr. Praveen Pai, and Dr. Deepak Davidson. Dr. Praveen Chanda is waiting online. Hand over the proceedings now to our chairpersons. What do you, sir?
Chandra sir, good morning. Deepak here. Sir, thank you so much for joining us today. We know that you are in a meeting, so thank you for taking time off and joining with us. Thank you so much. Please go ahead. So we can see you. Can we have the slides on? The video on? Sir, can you hear us? Chandra sir, can you hear us?
Hello. Hello.
So we can.
Hello. Yeah, I'm online. Okay. Am I ready now? Okay. 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 You cannot hear me.
So can you hear
can
us?
you hear me now?
Yes, we can hear you.
Hear me now?
We can hear you.
Yeah. So, okay, I'm
can
starting
you hear
my
us?
presentation now. This is a complex case. And before that, of course, it's a pleasure to be here on this. Of course, regret that I cannot be there. But, this is something, which I would certainly like to share with you. And this is a patient who came in cardiogenic shock and LV failure. And he was put on a balloon pump for several days. And then when we did the angiogram, we found that he has got severe MR and also got severe coronary artery disease. So the question was whether we start the whole thing now, together or one by one.
There was a link. Okay.
Sir, can you share your video? Sir, can you hear us?
Can you hear? Can you hear? Okay.
Verma, can you communicate to him that He's not able to hear us.
No, I cannot. Yeah. Okay. Okay. So I am continuing. Okay.
So his creatinine levels remain okay, but his ejection fraction initially when it returned, it was about 20-25%. Is stabilized now 3%. And then after that, still once he was stable, we did his transfusion echo, performed the mitral regurgitation, which is kind of wide open. Both the defects are almost not coaptic, but the lens are okay, and everything else seems to be okay. Now the angiogram was done. Let us see the angiogram which was done. We'll just replace that. Angiogram. So let us have the new angiogram. Can I start the new angiogram from as I told
So should I go back a little bit?
he was put on intravenous for visual stabilizing, no saturation levels when he came to the hospital. So he was in emergency under the balloon pump, and then after initial stabilization, echo was done. And echo showed that he got severe torrential MR.
Can you see and hear?
He started looking at his history, and now I will show you
Oh,
start with his first angiogram, which was done
okay.
in 2016. So the
So in this, as you can see here, that this is a multi-vessel disease with severe mitral regurgitation, and we have taken the patient on table. He's on a balloon pump right now, and we are planned to do the coronary intervention first, followed by MitraClip treatment in this case. It's a heavily calcified artery starting from left main, going to the, this LED diagonal, and also this RCA. Everything is like, it's a bad triple vessel disease.
So his creatinine levels remained okay, but his ejection fraction initially when it was about 20-25%.
So the first thing we are planning to do is to put him on a Impella and then proceed with the intervention as a mechanical circulatory support, because this is a very fragile patient with severe mitral regurgitation, low ejection fraction, and severe triple vessel disease.
Now the angiogram was done. Let us see the
Hello.
angiogram.
Sir, I'm Deepak here. We can hear you very clearly. And now I hope you can hear me also, right, sir?
No, I can. This is on the phone, but my laptop is having some issues. Are you getting my presentation
We are seeing your
audio
presentation. We are seeing your
and audio
presentation
of the
very
presentation?
clearly. Audio of the presentation is not very clear, sir. So if you can mute your presentation audio, and then if you can speak, it will be better for us. And keep your mobile switched on so that whatever doubts we have, whatever queries, we can speak to you over the phone also.
Okay. So okay.
You can
So I have
reduce the
muted.
video volume.
Okay. Is that okay now?
Yes,
Can you hear me?
Yes, sir.
Okay, lovely. That's fine. So you can see that the balloon pump is on, and we have decided to move ahead for the coronary intervention part as of now. And so in this patient, we did both the procedures, the MitraClip and the coronary intervention one by one. So the question was always there that which one we do first. And so typically we decided that since the MitraClip has to be done under general anesthesia, the anesthetist said that, and we discussed that coronary intervention has to be done first. Although,
the choice of mechanical support.
yeah, so the choice of mechanical support, there are only two choices here. IBP was already there, and we thought that it will be not enough. So we decided to go ahead with a 3.5 CP Impella for this procedure. And also at the same time, we decided that we'll keep the balloon on, and balloon will be there so that follow up, the balloon will continue till we do the mitra clip, maybe in 24 hours or 48 hours. So that's how the plan was.
So moreover, is it needed that when you do a mitra clip, you shouldn't be having an impella catheter inside the LV?
Yes, absolutely. We cannot have an impella dwelling inside, because then, of course, you cannot do that because of this device being inside. It may entangle and stuff like that. So that is why IBP can just stay there. There is no problem.
So things are now very clear. Please go ahead, sir.
Okay, okay. So we are, slowly moving ahead. And as you can see here, this is the, these are the diagnostic shoots, as you saw already. And now we are going ahead with the impella. So this is the sheath which we are taking inside. This is a 14 French sheath. And after the dilatation, it's on a, it's on a Amplatz wire. And we are going ahead with the sheath insertion very carefully, because there's only one side. The other side is already engaged with the IBP. Okay.
Yes, sir. So you'll be using the same sheath for the guide catheter also?
Yes. So this will be a single access. And for the single access, we take a 14 French sheath, which comes with the impella system. And then thereafter, we do the puncture in the same sheath. Once the impella is inserted, I will show you how we do it. And so this is the pigtail, which is being taken inside for the insertion of impella. So this is the pigtail. You can see the pigtail coming in, and on the same wire which we used for the insertion of the sheath. Okay.
Yes, sir. So the strategy is to open up all the 3 vessels?
Yeah, I mean, basically the idea is, because the RC is totally infarcted, so we decided to do the left-sided intervention predominantly, because this patient was under our follow-up for a long time, and he had an old inferior wall MI. The mitral regurgitation was continuing to be severe, and he was being managed on medical therapy. This time, he came with ACS and LVF. And of course, he had the background of severe MR, because many times people may discuss that why not just do the coronary and wait for some time so that mitral regurgitation may regress. But in this case, we knew that this also has to be addressed, because he was being considered for a mitra clip for a while.
Yes, so we see a significant cardiomegaly also.
Yeah. So this is the catheter, which is now being taken out of the the package. And so if everybody is okay, I can even move ahead a little bit.
Please go ahead, sir.
No, about this, should we jump the step of inserting the impella catheter?
So we would see the insertion of impella catheter, and the intervention part probably can fast forward.
Okay. So the most important thing is that this, you can see that there is a flag. There's a small flag there where I'm holding this catheter. So that should not go away. If that slips, then it will be extremely impossible to insert the catheter, because it is a small inserter, red color tube. And that is the way we insert it inside on this wire, which is a long 310 centimeter wire, which is there. With the help of the pigtail, we have taken it inside. Okay.
Yes, sir.
Yeah. So all the connections have been made, and you see this flag with that red tube.
Sir, and the wire is 018.
Yes, this is the 018 wire, which is extra support and 310 centimeter in length, exchanged length. And we are making a curve at the tip so that it doesn't, hurt the LV, and goes there through the pigtail and sits there like a, curved pigtail.
Okay.
So again, the intention of having the IABP is to have a better hemodynamic support in the post-procedure period.
Yeah, in the post-procedure period, and also taking him through this to the MitraClip till we do the MitraClip in this case.
Yes, sir.
Yeah. Otherwise, it is always a discussion why to keep that IBP inside. So because if you are already having the impella, so the other strategy can be that we keep the impella in and then do the procedure. But the problem is one of the vascular ischemic issues in the leg, because if you keep a 14 French sheath, there can be some of that. And the second is you cannot have the impella inside if you are doing the MitraClip at that particular time.
So moreover, is this the routine position where you keep the IABP, or would you usually
This is the little low. So this is a little low. Generally we push it up. So after this procedure we pushed it up, and so because during transfer I think this this IBP got little pulled, but we said okay, we'll change the position, because what happens is once we do all that, it is a little unsterile at that place. So we didn't want to do all that maneuver at this stage. So this is the catheter which is being taken inside, and you will see that it moves. And so we have done many patients who were on IBP and then subsequently switched over to Impella. So taking this device, and the balloon has been deflated, as you can see here.
Yes, sir.
Yeah. So now this goes inside, and you cannot keep the balloon off for a long period of time because thrombus formation also can happen, although the patients are fully anticoagulated. So we can do it 3:1 or something like that, because typically there is no need to have the hemodynamic support from IBP at that stage. But it doesn't harm, but it may not help. It doesn't harm.
Got it, sir.
Yeah. So the catheter is now in position, and this you can see that this small marker, this is in the insertion point where it is inflow point actually, and this is the outflow point. Okay. And once this is in position, we will move a little forward, and you will see that we have now taken the guiding catheter through the same axis, and this is through a Terumo glide sheath. So sometimes we take a Terumo glide sheath, and at times we take a destination sheath. So you can either use either of them, both of them work. But otherwise, it may be very difficult to move the catheter. It becomes very tough.
So for the benefit of people who are gathered here, could you tell us regarding that the 14 sheath and then the impella catheter occupies a 9 French lumen and you have extra space by the side?
Yes.
Something on that.
Yeah. So basically we do a puncture using a micro puncture, needle, or even you can use a normal needle, go on the side at 2 o'clock position, or maybe you can go to 11 o'clock position and puncture it. And then through that, we take first the glide sheath because it is, slides very well. And then you can use either a 6 French or a 7 French system, depending upon what you want to use. But if you don't do that, then just the guiding catheter becomes very, very tough to maneuver.
See, what sir has mentioned is basically the impella sheath is 14 French, and once the impella goes into the ventricle, the catheter size is only 9 French. So then you have an extra space inside the sheath, a 9 catheter inside the 14 sheath. So by the side of the impella catheter, you can take a guide catheter.
So the strategy here is that we recanalize this LAD to diagonal, because diagonal was a big vessel. LAD was also occluded for a long time, but we decided that we will do LAD also and use the LAD as a side branch, because this historically we knew since many years that this LAD is occluded and it is partially viable only. So we wanted the diagonal, which is almost as big as the LAD here. So We do go from the LED to the diagonal, and also at the same time keep track of this circumflex. So we are strategizing like this, that we do a LED diagonal bifurcation and use LED as a side branch. And then after that, we do a stent, crossover stent to left main to LED. Okay. And since it is calcified, we had planned to take a IVL for this case.
So which wire is this?
So this is a Fielder XT wire, which crossed, and as you can see that we are in good position. And of course, after this, we moved to another wire, which was taken into the diagonal, which is a huge diagonal, which is the most viable artery actually.
So we have one more doubt. While using Impella, would you always have a PA catheter and measure the PA pressures parallel?
We generally.
How often do you do that?
Yeah, we do always in cardiogenic shock patients, but this patient was like a high risk PCI. So in these kind of patients, sometimes we can just since we had the information about the PA pressures and the MR was a very predominant thing, so we decided that probably it may not be so necessary to do that. So here what we see is that this balloon dilatation is being done to the LED and the diagonal, and after that you started seeing some flow in this with the first with 1.5, now with a 2 millimeter balloon, and at this site you see that there is some calcification also. So first the dilatations, and here we do a this is a DK crush which is being planned, and this is the dilatation of the proximal part of the LED with this shock wave which went off well, and then subsequently we did IVUS. So the IVUS did not go from the very beginning inside because the calcification was too much. Okay. And then once the IVL was done, we were able to take the IVUS inside. Oh, there's a little.
So we see that you use a 20 megahertz catheter.
Oh yeah.
Do you find any high difference? Good difference between the HD as well as 20 megahertz?
So let me tell you, this is a very sensitive question which you have asked. And because many of my friends who are tuned to the Boston HD system, they just swear by it. But let me tell you, I was using earlier the Boston system, but I find this much more easier. Okay? Because what happens is that, it is a plug and play kind of thing. And once you get tuned to the images, it becomes absolutely, immaterial, because whatever information you would like to have is easily available with this catheter. So in my cath lab, with the use of imaging has gone up predominantly because it is so easy to do that. Yeah.
User friendly and quick to use.
Yeah. So here you can see that, we were not able to cross the IVUS beyond that calcification point. So we are doing this IVL at this particular stage at the bifurcation point, and then the IVUS goes inside, you see. And this IVUS catheter this is the eagle eye catheter, which has 3 markers also. So the total length becomes 32, 10, 10, 10, and then 2.5 of the distal imaging point. So one can easily check the, the size, the length of the vessel, etc. So it's not so difficult. And it's manually operated. Okay. So once we have done that, we will now proceed for the. So you can see that both the vessels are now flowing well, and there's just one more, I think, IVUS here, and then we proceed with the stent. So this is a stent we are going to use in the side branch. So LED is the side branch here. Okay.
Got it, sir.
Yeah. Yeah. Okay. So now once the stent is in position, we take the balloon for the crush on the LED diagonal position. Okay. Yeah. And then we implant the stent in the LED. Yeah.
In size based on IVUS 2.5
Yes.
or
Yeah,
so.
2.5 or so. Yeah. So once that is done, then we check distally if it is okay. Looks okay, but finally we will do another stent distally because we thought that probably the artery was underfilled, it will grow a little more, but then we will do that. Okay?
Yes, sir.
Yeah. So we do an IVUS again at this stage. I think I'm just forwarding a little faster now.
So we have some 10 minutes more, sir.
Yeah.
Can
So,
we
I'm going a little
forward
faster.
the portion alone?
Yeah, I'm doing that. Now this is the crush which is happening. You can see we are crushing the stent in the left LED from the mid to the distal. And then we put the wire again, do a kiss. And then for this, the kiss which is happening. Okay. And subsequently we put the stent from the left, left main to the LED. Okay, and the distal stent was implanted at the same time beyond the, you see, the distally the vessel is flowing nicely, the LED, and this is the second stent which is coming from the left main to the LED. I'll just show you quickly. This is the post dilatations and then the using a bigger balloon in the proximal segment. And let us see. And then finally we did a final kiss at the bifurcation point, do an IVUS, and then this is the result. You will see. Okay. So all the vessels are flowing well, and we then said, okay, fine, we'll stop here, and then we remove this impella. So we're removing this impella on the table, and the balloon is then subsequently, activated, and we take it out and close this site with a ProGlide, which was implanted before this insertion of the sheath. Okay.
So you use one ProGlide alone?
Yes, generally we use one ProGlide and one AngioSeal, or sometimes one ProGlide also does the job and do some gentle compression. Okay. Now,
yes,
yeah, this is which is already done, and we'll go to the MitraClip part, where you will see that this patient has severe mitral regurgitation. Let me just show you the initial this thing. And so this was done in 2 stages, and then subsequently this was quite this is the first clip which is being positioned here. You see the clip?
Yes,
and this procedure also didn't take too much time. It took about 45 minutes to do the whole thing. And our clip time is generally now, the whole procedure time is 45-50 minutes. Clip time is 20 minutes.
And is it usually done under GA?
Yes, always, because it is a T-guided procedure. So you cannot do without GA. So that is why we had to do this. Earlier, we were thinking to do the MitraClip first, get more stability from the mitral regurgitation viewpoint, and then subsequently do the intervention. But here we do it this way. So you can see that we are doing the imaging at all stages is very, very important. So we are looking at the, the gradients at the across the mitral valve and also the pulmonary venous flow. So, and these are the two views which we use. Typically, the bicommissural view and the LV outflow view.
Yes, sir.
And the third is the 3D NFAS view. So you can see that these leaflets are now coming, and so we have to position the clips in a way that it actually starts holding these two leaflets. And you can see that the PML is very small. So we have to, too small. This sometimes, many times it happens in basically functional MR. So we have to maneuver the positioning through the help of, these catheter movement, the SGC and the clip, the clip device movement. And
So what's your usual experience, sir? In dilated LV, you need more than a clip, or?
No. In fact, in dilated LV, most of the times now with the XTW clip, which is the bigger clip, it is a one-clip procedure. I mean, it is, and then the second clip could be a smaller clip, maybe just a XT or a NTW or something like that. But the main thing is that the first clip should be done very well positioned. And also we look at the MR, how much MR this patient has. So here you can see this is the 3D NFAS view. And we are trying to position the clip based on the jet, which is coming either in the center or in the medial side or in the lateral side. Yeah. So this takes time to control that. Hello, can you hear me? Can you hear me, Dr. Deepak?
Yes, sir. Yes, sir.
Okay, so you see that we are now looking at the jet and the position of the clip. Okay, so we do that, and subsequently the clip is closed. Now you see both the leaflets are being captured, and then we find that probably it is not good, so we can open it up and try to reposition it. Okay, so we are again captured it and see that there is still some regurgitation. So we keep checking it, and unless until we get at least 50% reduction in mitral regurgitation, we just continue that. So I think now we see, okay. So I'll stop sharing now. And basically, so both these procedures were done to this patient, and then subsequently the patient was discharged in 2 days' time further, and he's doing very well after that, because he was going into recurrent hospitalization for severe, heart failure and because of severe mitral regurgitation, which has regressed, and his coronaries has also been addressed. So I think that was a long procedure for him, but really very helpful to stop his frequent hospitalizations and symptoms.
Sir, on follow-up, what does the data say there regarding the left ventricle size? Does it come down? Remodeling happens?
Yeah, basically it will also depend, of course, on the medical therapy which is given to these patients, and these patients definitely improve both in terms of the LV remodeling, the symptoms, and the need for hospitalization. Yeah.
So just one question. What is the role of mitral clip in acute mitral regurgitation?
I mean, that is a little tricky situation. So I will say that those patients where the centers have not yet started doing, clips in, chronic patients, and they're doing acute patient is very, very tricky, because the LA is very small in size, and these patients are really sick patients. So there one has to only start doing it once you have done at least 30, 40, 50 clips in stable patients.
So Dr. Anil here.
Yeah.
Thank you for sparing your Sunday and coming over live for showing this case. Very interesting case.
Thank you. Thank you very much.
Thank you, sir.
Thank you.
Thank you very much. Thank
Okay,
you.
bye. Bye.
Thank you, Dr. Praveen Chandra. Thank you to the chairpersons of this session. Move on quickly to the last session, management of complications. May I please invite the chairpersons onto the dais, Dr. Saji Kottukulam, Dr. Gerald Werner, Dr. Pratap Kumar, and Dr. Hazra, please. The first speaker, Dr. Vijay Trehan. Welcome, sir. (15 minutes plus 5 minutes discussion).
I can finish my talk in 2 minutes. On me.
We have a very long session to go, so please start off, sir.
At least let us start. So, I'm asked to speak about as to how to do complex cases and high risk cases, and that too with utmost safety. I think even a small point in this CHIP meeting means if you talk about complexity, the calcified and total occlusions and all, if you start talking about it, even that will be a big topic. Anyhow, let's take a prototype. Out of the complexities, I think Dr. Werner and Pratap are here doing CTOs, where this is the most severe form of stenosis, and yet treatment is denied to most of them, and the pretext is many. A lot of people will say, well, this is a well-collateralized vessel, as a natural bypass, where is a need? And they will very cleverly give you an example of decision CTO. On the contrary, if you have a lesion like this, they'll pounce on to handle this lesion, and we'll never talk about an FFR which is 0.92, and we won't even talk about Orbita trial. The fear is of failure, and not only of the failure, complications. And if you get them, then there are many to criticize, only few to support you. And experienced operators like Dr. Werner and Pratap, just in case they are into deep water, they'll be able to bail themselves out. But many of us may not be as skilled and able to get out. So what is the best way? I think best way to prevent is don't indulge. Don't do it. Which many of us are clever and smart enough and skilled enough not to do it. But if you have to do it, let me tell you, it usually does not ask you to do big heroic things. Only what is required is stick to basics. And all of us know that we have to stick to the basics, but once it comes to performance, then many of us forget the basics. Look at him. He is one of the greatest bowlers of all time. Was he the fastest? Or he's the one who could swing, cut, or bounce the maximum? I don't think. He's a man who stuck to the basics, just accurate line and length. That is all what we are supposed to do it during handling CHIP CTO cases. And also, don't forget that you are not alone. It's a teamwork. And some of those people in the team who are not so skilled, maybe given a simple job like sit in the cath lab, keep loudly telling you how much is the radiation, what is the contrast, and what is the ACT. And have a system in place. By having a system in place, what I mean is you should have a checklist in the ward or in the ICU before a patient is sent to the cath lab. You should have a checklist in the cath lab itself where you should check everything, because many times halfway in the procedure somebody will tell you that creat is 1.9, by that time you already shot 200 cc of contrast. So you should have a checklist. And most importantly, debrief. Before starting the case, like Dhoni is on the field, he's talking to everybody after fall of a wicket or before starting a new thing, discuss. What is the plan? What are we going to do? So that everybody in the team should know what is going to go. Now, we start from the groin. We should know what is a groin, both from in front as well as lateral. Not only in the pictures in anatomy book, but on fluoro. And not only on fluoro, we should also know how to use a micropuncture under ultrasound. So we should know what is anatomy in lateral view and on the body itself. If you have given a high stick, where to compress. If you have given a low stick, where to compress. And many times we are saying we are kind of puncturing the artery on femoral head and we are pressing there. But let me tell you, if you have the anatomy, femoral head is not compressed. All what you compress and feel is pubis. So those simple things have to be known before you embark onto a femoral. And let me tell you, most of the time it is a general compression. So you should know where to compress, high puncture where to compress, lower puncture where to compress, or else you will get into complications. Now, as far as fluoroscopy, ultrasound and micropuncture is concerned, you will find a lot of time there is a debate that you should puncture with ultrasound or with fluoroscopy. Well, let me tell you, no debate. Ultrasound will tell you that you are above the bifurcation, which you don't know while you are puncturing on fluoro, because fluoro you will know about the puncture only after you shoot. But ultrasound will tell you if punctured above bifurcation or below bifurcation, which is important for your stitches. Whereas most of the cases, you need to have a hemostasis by compression. So ultrasound will never tell you whether you are puncturing at a site which is a good site for compression. That will be told by fluoro. So don't kind of mix them. Puncture under fluoroscopy if you want to have a compression. Maybe puncture under ultrasound if you want to use a closer device. And also, don't forget that after you've had a puncture, just before you want to fully anticoagulate, take a shoot. Be sure that nothing is bleeding. Because sometimes even tiny holes, but if you let them kind of bleed, they will continue to bleed with the procedure. Let them seal first before you anticoagulate. And post-procedure, if you have hypo, initial hypo could be vagal, but then don't think it is vagal if it is an hour or a couple of hours after the procedure. Because then you should think of an RP bleed and no CT or CT angiogram. State of the patient should be in the cath lab. These are the ways you can kind of take care of groin problems, anticipate them and preempt them. If the groin is not very good, then you should be able to have an access, either axillary or maybe transcaval, and not only get an access, you should know how to close those transcaval vessels with the help of PDA devices. And a lot of time there is a debate, radial versus femoral, and a lot of people will advocate one or the other, but I'll say both. You should know to puncture both the areas and know how to get them inside. All of us know that your support of the guiding catheter is not very good if you're coming from above, from the radial, because the theta angle is big if you're coming from femoral, but that can be preempted by some of the specialty catheters, like Ekari, if you're using from above, will give you equally good guide support. Also, the space is less from the radial, but I think to increase the space, it is better to use sometimes specialty sheets like sheet from Termo, which is slender sheet, which is thin walled, which will let you get 6 French sheath, you will let you get with a 7 French catheters, and also nowadays we have a sheathless catheter which you can go from the radial. So both radial and femorals can be used. You have to learn how to use them. Many times the catheters will move. Now if you see, look, this is a catheter which is coming, and this is moving in and genting in. So there is something like, if this is a catheter which is coming from femoral with deep breath, both will go down. Both will come up with expiration. Whereas if it is a radial catheter, somebody takes a breath, it goes. So sometimes the support is lost from radial. So we should know it. If you have to take on a difficult RCA, it is better to go femoral rather than taking radial. And one must avoid a radial, especially if it is feeding the other carotid through the circle of Willis. Now, second thing where you can get into trouble is as you take your guide in. You can get into trouble if there is osteoproximal disease, your guide catheter can create a dissection, and worse could be if you inject. And worst will be if you have aggressive guide and then you inject. And then this can lead into kind of these dissection which can go up or down in the form of aortic regurgitation or up into the carotid and compromise them. So avoid aggressive guide catheter, you want to avoid complications. Use long sheaths and guide extension instead. And for the right, always take a RAO view for coaxiality. I think most of us forget about looking for coaxiality in the RAO view. Side holes, no guarantee. You can have a side hole, you can get into troubles. So it can sometimes give you a false sense of well-being. You can even create a complication far away from your catheter. Like this catheter is injecting, it is wedging into the conus, and if you look at it, the conus is getting a bleed. So no instrument, it is just a power injection to the conus and it builds up. So you do not necessarily have to have instruments into the vessel to create perforation. just a wedging. So power injections, wedge injections can do great harm. And in this case, there was an SVG into which injection was done, which created perforation, avulsion of the guiding. Coils were put, and even after coils, the injection was again kind of wedge. This just kind of took away all the advantage done by the coil, and wedge injection reopened the hole which was created. So dictum is don't wedge inject if you want to avoid complications. Here this RCA is being done, it's retro, and it was relatively simple. RCA was done, good result. And the only problem was noticed that this feeder guiding created a dissection into the LM. And this dissection occurred at a time when there was an exterioration of the wire was pulled from the RCA recipient vessel. So if you have a wire which is exteriorized, either you can trap it or you can catch it with a snare and pull it. But pulling is wrong. If you pull it, this will try to suck in the guiding. So best way to handle the guide in such a situation is keep pushing your feeder, and the feeder wire or the wire or instrument should be pushed, not the recipient vessel gears which should be pulled. That's all you can avoid. So there was a debate about which MCAs one should use. Well, I'll say that all of them can be used. IBP, I think most of us have excess, and probably it does nothing, half a liter. But some of the patients with the multi-vessel, some of the operators are not very confident, can use it with some kind of LV dysfunction. But if you have a major LV dysfunction, you want to do a real chip case, you want to do multiple vessels, then I think for the ease, a lot of us will try to use an MCS, and the best will be Impella and Impella CP. But one must not forget that you might have some groin issues in the form of a 13 or a 14 French and cost. But AMI shock and these patients, I think there is not big debate that these patients can be supported with the help of Impella. And as Dr. Pratap was saying that you have to go through the valve, so you have a non-transvalvular devices in the form of tandem heart, which can be taken care of in patients who have aortic valve disease or a mitral valve disease, and also who have hypoxia. You can use tandem heart, and in real crash situation, you have to use full bi-V rescue support with hypoxia. Of course, you'll have to pay in the form of very large excess and sometime loading of the ventricle, which may require a vent and pepping this time. I'll come to this issue a little later. So most common problem with cheap CTO cases is a perforation which can be in the body or in the distal vessel or a collateral vessel. And a body perforation usually is in the situation when you have an ambiguous body and a long tortuous segment where you use a hard stiff wire, and especially if you pass gears over it. So good thing is try and traverse this area with the help of a knuckle, because knuckle most of the time can be trusted. And if you have a retrograde access, then try and see whether the things are moving in the same plane. They are dancing in the same plane. If they are dancing in the same plane, then I think you can probably take your gears over either antegrade or the retrograde bar. And sometimes it is good to know the anatomy pre-hand by using a CT. The perforation of the body is very often because of oversizing, and if you use intravascular ultrasound, most of the time you can avoid this oversizing. This is clearly an oversight, but sometimes in a CTO body, like in this patient, this stent in the mid RCA is not oversized, and this was sized by IBUS, and sometimes these areas of CTOs may be negatively remodeled, and these negatively remodeled areas, if you size them with the vessel proximal and distal, sometimes this may be in fact oversized. Despite the fact you are doing it with the IBUS. And especially in elderly people, ladies with heavily calcified and tortuous vessels, especially these frail ladies. And if you are sizing in the subintimal area and sizing a vessel with a subintimal vessel size, then this is sometimes oversizing, and using a balloon or a stent according to that might lead to perforation. Many times a distal perforation which is there, and I think is it there or not, so you really want to see it better, you put the guide in and try to inject. So you try to see it better by putting a guide in, but all what you have done is made it worse. You want to see it further better, your guide is further in and you are injecting. So these things should be avoided. Means if you have to really see, take a microcatheter in, and you can just have a microcatheter non-wedge, and that can tell you. So you can possibly avoid some of the big complications. If you have a wire exit in the middle of the body, only wire exit and no gears going out, then most of the time it is forgiving. You pull the wire, things will seal. And if you are able to just pull the wire, things will seal. And in case you have been able to cross it, then you will be able to put the flap back, and almost never you will get this perforation which was seen in the middle of the procedure seen after the stenting. So that will kind of seal off. You must watch out for your tip of the bar, especially if it is a stiff tapered polymer jacketed bar, and watch the tip while you're advancing, as well as withdrawing the gears. And if you want to extend and trap, preferably avoid using Nento technique, because that can blow out your bar. And just in case you get into trouble, I think you should have systems in the form of microcatheters, specialty microcatheters and specialty bars, so that you can seal them super selectively, as was done in this case. Anytime you have a wire movement like this, I think you should know that you have done mistake. And if you have a contrast which is leaking and getting off very fast, that means things are gone. I think since I'm running short of time, in the septals, I think one should always try and avoid these kind of acute angulations of your septal collateral, because acute angulation will lead you into trouble and produce septal hematomas, which might require surgery. So I think I can quickly go into my concept of chip. What I feel is that all those people who are doing chip should learn how to start doing simple cases. I'm just skipping in the interest of time because there was some. So chip is a term, complex, high risk. And most of us are doing initially simple, low risk cases. Don't see these slides because I'm just running them fast. I'll come over somewhere. So most of us are starting with simple, low risk cases. This is SLIP, my term. This is slip. So if you are doing slip cases, then you should not do silly mistakes like shooting in air, shooting in thrombus, and doing a guide catheter avulsions, because you can never be forgotten for that. So this is what it is. I say don't slip while doing slip cases. S is simple, L is low risk. Like this is a simple case. Good LV, apparently elderly people, good health, don't slip. So most of us know how to do it, but do it without common simple mistakes. Pushing in air, pushing in thrombus, guide catheter, wedged in and then injecting. So then you'll be in a big problem. Now, there's a lot of debate. Should you use MCS or not? I think no debate. If you're working in a center where MCS is being used everywhere, you must learn to use it. Because if you don't learn to use it, then there is a situation when it is really needed. How will you use it? How will your people learn to pay for it? They will never learn. So I think those centers where MCS is being used, they can learn to do chip cases. They should do SHIP. SHIP means simple, but high risk cases. Like this case, it's simple. Left main, it's high risk. Why it is high risk? Low ejection fraction, low blood pressure, fast heart rate, high PA pressures, and low PA saturation, low cardiac output. This is what done. The guy knew, he was a resident, he knew how to put a MCS. He quick laugh. Some of you were senior enough, they were saying, Dr. Chanda to show, how are you taking your Impelline? And even Dr. Davidson was asking, well, everybody should know what is like, but this is a pigtail. Doesn't require anything. But this was taken by a resident, he took in, and this angioplasty can be very easily done by the resident, he did it. And 3 months down the line, this patient quickly improved, his ejection fraction shot to 45. What more you need? So, no debate. Where you have MCS, you must learn it. However, everywhere this will not be there. I was trained at a place where MCS is not there. I was like, Pratap. So if that is not there, you do clip. So I have talked about slip, SHIP, and clip. Clip is you do complex cases which are low risk. Now this is a complex case. This RCA is a CTO. People tried it antegrade, could not do it. This was tried retrograde and was done. Apparently it's a complex case. But substrate is very good. 60% ejection fraction, good blood pressure, good pulse, normal PA pressure, normal oximetry. No issues. Kidney is normal. So while you are doing this, you improve your skill set. And as you are improving your skill set, you should know which wires, which devices. You train yourself. And once some people are doing shipping, other are doing clipping, they should talk to each other because both are doing good job in different platforms. And finally, both of them can take on real chip cases. And but I'll say shipping should start interacting with clipping, and clipping should start shipping interacting with clipping, and finally doing ship fine, and clipping interacting with shipping means learning to put MCS devices, and finally doing chipping. Why it is important is because sometimes you might get a case like this. Elderly gentleman, he's brought with 4 or 5 days chest pain, pulmonary edema, collapses, put intubated, low ejection fraction, moderate to severe MR. Don't wait for mitral clip. PA pressures are high. PA sats are very low cardiac output. AVR is elevated. Look at this anatomy. This patient's already put an Impella. LED is straightforward. Anybody can do it, but with this kind of anatomy, with occluded circumflex and occluded RCA, I think even a simple looking LED lesion will become difficult, because the moment you inflate a balloon, everything might just stop. Look at this. The circumflex was done on this, and then the RCA was done retro, very easily completed. Dr. Werner, of course, will do it antegrade, but not everybody will do it antegrade. And then this distal LED again on Impella was done. So this case was made relatively simple by having skill set to handle those difficult anatomies and having MCS to handle simple anatomies but on a difficult wicket to bat on. So I think no debate. We should try and learn and have skill set for both the things, and also let the public and the taxpayers and those who are doing reimbursement know there is something like Impella and they need to reimburse. If they are reimbursing cancer people 1 crore rupees, why should they shy away from reimbursing 30-40 lakhs for this? They are putting heart-lung machines and they are putting artificial VADs and so on for 1 crore rupees. I think no debate. We should all learn. Here is a case, and this had MR. They had a complex RCA lesion. And if you look at this LED, and Pratap will see it clearly. This is LED. What is this? This is one branch. This is not LED. This is diagonal. That's septal. LED is somewhere in between. I really didn't know it as to where it is. And finally, I was able to do it. No Impella. Nice result. And similarly, this patient, we were not able to clearly see where is the left main. Finally, we reconstructed the left main without seeing it. And this patient with the LED lesion, bad kidneys, just slipped in a microcatheter into the LED to show hardly any contrast use. And how to hook the catheter without putting contrast is just send saline into the artery. Just see the T waves going up. That tells you you're into the coronary artery. No need to shoot in contrast. So 5-7 ml contrast was used in this patient, and that was the final result. So we have to develop our skill set and develop our methodologies so that we can handle many of these cases in a relatively simple way. And I think I can stop my talk here. So this patient also had an MR. We didn't use any mitral clip, and these patients all did well over a period of time. I think in the interest of time, I can just stop cases.
Thank you, Dr. Trihan, for the excellent talk. Let me have some comments from.
Yeah, well, you covered the whole spectrum of complexities, and the question is, how often do you use MCS now?
Very rarely. Very rarely. But at the same time, my humble submission is that a lot of us are not so skilled. I had a lot of cases, like I wanted to show that a lot of cases which were much worse than what was shown by Dr. Praveen, and bad anatomy. This was a relatively straightforward LED. Bad anatomies. But I think at my level, I think we have developed skill sets, and my sympathetic drive at the time when things are not going the way is not as much as it used to be some 2 or 3 decades ago. But for a lot of us, what is there in putting an Impella? Nothing. All what is required is just get into groin. You should know, as I told you, the principle, puncture anteriorly under ultrasound. Don't go here and there. And after that, what you have to take is just dilators and then that 14 French sheath and ultimately pigtail into the LV, and then the thing is doing a job. There is absolutely no doubt that sometime when we are doing these complex cases, your hemodynamics will go down. And if the hemodynamics go down, then I think it is not a good thing to have somebody doing a CPR and then trying to cross it. And once in a while, all of us who are doing these complex cases in the absence of MCS will have these things. And if these MCS devices, अगर वो आपकी जेब ना काटें, आपकी body को ना काटें, means if they are not costly and if they are not, you don't have to pay too much things at your groin in the form of a 14 French puncture, then I think not that big a problem. And it's okay that large number of these devices being used in US because of financial reasons and also because of legal reasons.
Right. So I think great lecture. Just to put my 2 cents here,
Nowadays, you should adopt a CT scan before doing a complex CTOs, failed CTOs, high JCTOs, coronal angiogram. So
Well, a
that
lot of them have renal dysfunction, so you
so
cannot
if
do
you-
them.
no.
In fact, large number of my patients, I try to finish them in 10, 12
I did not
cc of
complete my
contrast.
sentence. If your renal parameter permits. Now, may I ask you one question? How many of you know Penumbra, and how many of your centers having Penumbra system? Anybody? Penumbra, yeah. In situ and Penumbra. If you have a Penumbra, if you have pericardial tamponade, you just connect the pigtail with the Penumbra. It sucks like anything rapidly. Second,
You can put, Dr. Hazra,
So let-
you
listen,
you can put another assistant of yours who's the least
okay,
skilled
okay,
with a
but-
syringe in hand, which works like Penumbra.
It works like it takes 10 minutes, but the Penumbra sucks within 30 seconds.
Somebody just doing it.
Let
60
me
seconds.
finish, sir. Let me finish. Then if you have a Stingray, if you have subintimal hematoma, connect to the Penumbra. You don't have to put the syringe. And third, if you have a perforation, microcatheter Penumbra, that seals. These are the 3 tricks I wanted to, because you are the master of giving tricks. So I am just following your path.
Nice way to calm me down.
No.
I think in the interest of time and some
World Cup.
upcoming events, thank you very much. And I think the one inserting the impeller is no problem, but closing these big bores, and I think that leads us to the next talk.
That's why I say that these are, again, they are so simple things. In my experience, I think they are much simpler than crossing a CTO, especially a CTO, some calcified and a tortuous one. Impeller putting is almost nothing. It's a very, very simple device. Only thing that people have to pay, let them learn how to pay for it, because all the time you are burning your own fuels and you are scorching yourself. Why? There's absolutely no doubt. If I remember, I have joined a new center, and the last 1 year I have used Impella in 5 cases. 4 of them had a real hemodynamic compromise during the procedure. Real hemodynamic compromise. 2 of them had arrest. The anatomies are like this. EF is 10 to 15%. But with Impella on, we were able to do the job relatively coolly, and all 5 are living. Unlike Pratap's 2 cases which he lost, all my 5 cases are living. And I still say that these are good devices, but at the moment the cost is exorbitant really, and I really fail to understand why the cost is so much. But for our health and our kind of, we also don't need to have too much of adrenaline kicks into our body and at our bifurcation lesion, even at left main, for making us future LM bifurcation patients. I think these devices are good, and we have to learn them in cool way. If you want to do it in a case who's really complex, that's not a time to learn. I think you learn them easy way, and the best will be to learn them in patient with cardiogenic shock, where you have nothing to lose. Cardiogenic shock, just put the device and be happy, and learn to close them. And nowadays with the same sheath, using for the guiding catheter, I think it is easy enough to do even interventions.
Thank you,
Yes.
Dr. Trihan. Thank you for the few hours that you came. We have been doing CHIP for 25 years, and without you, this meeting would have been incomplete. Thank you for all the sacrifices you made. Thank you.
Yeah, thank you very much. My purpose was actually to lead to the next talk, because sometimes retroperitoneal hematoma happens, and we'll hear about that. Dr. Rajiv.
Good morning, respected chairpersons. First of all, let me thank CHIP team, Dr. Rajshekhar and Dr. Anil, for having me here in this wonderful learning experience. The topic here is retroperitoneal hematoma, already introduced. This is a potentially life-threatening non-cardiovascular complication. The access site femoral bleed can have 2 consequences. 1, groin hematoma, or second, a retroperitoneal hematoma. Incidence is, in literature, it is very varied. It is somehow more common in females, and most often with a high needle stick. I think we all suspect hematoma post-PCI, especially when there is hypotension. It is associated with abdominal pain and nausea, sweating, and we suspect retroperitoneal hemorrhage if the access site, you see the groin, but you don't see anything abnormal there, but the patient is dropping BP unexplained. Whenever we suspect bleeding, first institute is general measures. Obtain a large IV or central venous access. Normal saline administration. If you are too much normal saline, try colloid. Hemoglobin and hematocrit measurements to follow, and have someone ready with cross-matching part, send a sample, and reverse anticoagulation after the diagnosis is established. Now, why this is important? Because very simple fact that this space, which is the what's the zone C, that is the pelvic retroperitoneum. That's what we are interested in. This part is a very loosely packed space. So here, above the femoral sheath, which encompasses all the femoral artery nerve, above the inguinal ligament, once the blood starts seeping out, there's a large space apparently without any outside bulgings or outside manifestations. So a very loosely packed space where large volumes of blood can go in and cause hypotension. How to deal with? Now, if the patient is still in cath lab or brought back to the cath lab, the first is to do a simple fluoroscopy of the bladder, and then a femoral angiography. The bladder, this is a very classical sign which has described years ago, the dented bladder and fluoroscopy, which shows, you can see that the bladder image, you can see one side is actually pushed, caved in due to the hematoma. So this is how a normal bladder would look like on the left side, and a dented bladder showing a large hematoma collection on the other side. Now, a practical consideration in many of the CHIP cases, say the dented bladder may not be seen when you have a catheter in situ. You can't see the bladder at all. So what we can do is once there is hypotension, we can gently clamp the urinary catheter for 10-15 minutes and push in some fluids, and then have a check. We will see the bladder nicely. The second part, immediate part to do is, obviously, we all do a femoral angiography. A femoral angiography can be done either from the groin, from the femoral sheath, and this is a case which we had some few months ago, which showed a leak into the retroperitoneum. And whenever we have a leak into the retroperitoneum, it is better an access to be taken from the contralateral side. A contralateral side injection, coming from above down, shows it better, and the tackling also is better from above down. Now, this is a little detail into the anatomy. See this bleed, how this retroperitoneal hemorrhage occurs. This occurs most commonly from a higher puncture above the inguinal ligament, that part of the external iliac artery, you can see there, which is bleeding. And many a times, it is not the artery which is bleeding. See, if you have a high puncture, you have a diseased artery, that run can bleed, yes. But many a times it may be a wire which is going to this notorious culprit branch, that inferior epigastric artery, which is actually a muscular branch, which comes in an angle, such an angle that sometimes a difficult manipulation of wire, the wire may actually go into the inferior epigastric artery and damage it. And we might think that wire is going up the iliac. So this is one very, very common area. And these two areas are the main areas of bleed, either the external iliac artery per se or the inferior epigastric artery. When we have an active bleeding, the first thing that I usually do is a balloon tamponading. That is, occlude the area of bleed with a balloon. And if it is not able to stop with balloon tamponading, it's a small vessel, we can go with occluding things, putting things like coils, embolization, or placing a covered stent across a small branch, But if you have large vessel perforation and not able to stop, you'll have to put a covered stent or call the surgeon in. We'll come to a few cases. This is one case which showed a small leak which was causing hypotension, hours post-procedure, and this patient was tamponated with a balloon, I think it's a 5 mm balloon or so, and then after for 3 to 5 minutes of balloon occlusion, it was occluded. I think that was not running anyway. So this is one important aspect. For tamponading, we should place an adequately sized balloon. So we have to see our shelf and get the available balloon which is of adequate size. Usually, a 5 or 6 millimeter is the usual size of the balloon, but we use. Now, there's another case which is another elderly gentleman who had a bifurcation PCI, and after a 7F sheath was used, and the person had persistent hypertension 1 to 2 hours later, and then the patient was shifted back to cath lab. He has told already, when you have an unstable patient, there is no role like CT or anything, ultrasound or anything, shift back to the cath lab. This is what we saw. The patient had a leaking muscular branch of the inferior epigastric artery, that was causing the hemorrhage. And then first tried with a small coil. A coil was put into that branch and just waited. But even after coiling, it was not occluding. I tried after coiling, again balloon terminating, and put some time and just see, waited. But then even after waiting adequate time, still was not stopping. Then what to do? Waited for some more time. Anyway, so it was a small bead. We had arranged blood and gave transfusion. But then it was not stopping. This is something which came handy, that is embolizing with particles. The gel form was scraped into small bits and made into a gel form slurry with this agitating over a three-way and made a slurry. And then it was injected. So this is gel form being injected over the coil, and then subsequently with the gel form, that bleeder could be it's sealed off. You can see that. So that is one situation. This is another situation where another patient, again, here is also that bleeder, you can see very well, that bleeder. This is a slightly oblique view to show that inferior epigastric artery very well. So you can see that it says, luckily this origin of that artery was very near to the inguinal ligament, much nearer to the to our puncture site. And
just a minute, why didn't you put more coils before thinking of gel form? You could have put 3-4 more coils there. You could have done the same job.
Yeah.
Proximal, larger coil, more coils. Okay, go ahead.
Yeah, I'll come to that. Anyway, this is luckily this since this was a very accessible area, putting compression on that area for some more time, managed, and the bleeding stopped. And this is another situation where you have a rupture of a large vessel. See, if you have a large vessel like externally a artery ruptured, then it is very difficult to manage with the balloon terminate. Ultimately, we'll have to go in for either calling a surgeon and put a covered stent. But usually this occurs when you are planning for a high-risk procedure, when you have structural intervention at hand. But then always we should have a backup kit for vascular complications. Should be ready at hand. And if this happens outside cath lab, the patient is in CCU and the patient's hemodynamic is stable, then we can have an imaging and CT, and then if there is no active bleeding, we can go conservative with replenishing blood products. If there's active bleeding, there's nothing, we have to intervene, shift back to cath lab. There's a CT which it can be very gross and very massive sometimes without the patient have any external hematoma. To summarize, suspicion of bleeding when there is unexplained hypotension in a post-procedure patient. Think of retroperitoneal hematoma when no obvious hematoma. Work towards general measures. First, stabilize the patient. A contralateral injection, we should have a low threshold in doing. It gives you good information, gives you easy access to treatment. If a leaking vessel is found, endovascular approach is safe and effective, and early suspicion action saves life. Thank you.
Thank you, Rajiv. With regards to retroperitoneal hematoma, it is important to diagnose it early because any patient with unexplained hypotension, they may not have any abdominal pain or nausea. So look at the heart borders and then look at the bladder to see that these are the two things. And it's important to diagnose early because if you think that the hypotension is due to some stent thrombosis or something, we might give intracoronary tirofiban or something, and that might actually make this worse. So it's important to get it early.
You're right. Are you still a radialist or femoralist? Are you a radialist or femoralist?
See, it is both.
Why?
Yeah. See, we have to see when we have to have access with larger sheath, when you have to have a complex procedure, I still believe we should have femoral. Two things. Why?
What is your largest sheath you have used in a recent time?
Okay, so no, for a large sheath I have used maximum use for femoral 8 French maximum. No, I get your question. No, the reason, one more reason is, see, we should have our system familiar to tackling femoral problems. See, what we happen, we go all radial. See, your staff, your support staff, everyone, see, the femoral, the simple femoral sheath removal in an obese patient, etc., becomes a very rarity. And that is where I believe we will have complication comes in. So we should have a system tuned to both.
I think
That's
in
a
some
big
cases
point.
you need.
That's a big point. Good
Yeah.
point.
You need
Because-
sometimes femoral. I don't
Yes,
disagree.
yes.
Yeah, disagree.
Because the cath lab staff is many of the time they are not tuned to doing femoral compression and all. We don't feel confident leaving the cath lab.
How often you use ergotraben like thing in the past, Bivaludin or ergotraben now? Ergotraben, like an alternative to heparins.
It is very
because you have a
aggressive.
frail patient, a female patient, tortuous arteries, difficult puncture. Instead of giving heparin, I use ergotraben in most cases.
No, I don't. I don't have any experience.
Anyway, good talk.
Thank you, Raju. I think we'll move on to the next talk. Femoral artery pseudoaneurysm. Dr. Rohit Nair.
Dr. Rohit is an interventional radiologist in a new territory, but he is a very aggressive interventional radiologist. He does a lot of aortic interventions, vascular interventions, and a lot of peripheral artery interventions. So he's the right person to talk on femoral artery. He works at Aster Medcity.
Good afternoon to respected members on the dais and off the dais. I'm quite surprised that so many people still waiting in the hall. We've got a big event coming across. I'll keep my talk very short. I'm Rohit, one of the interventional radiologists based at Aster Medcity, Kochi. So with your permission, I'll start. This first slide, I'm going to talk about pseudoaneurysms. Does that anybody has a clue what this sign stands for? There's a name for it? Yin Yang, yes, very correct. Yin Yang. So we'll talk about that later. I don't have any disclosures for this particular talk. So people talk about, so if you've not had a pseudoaneurysm either, as an interventional radiologist or a cardiologist, either we are not done enough or we are not telling the truth. So pseudoaneurysms are very common. Now, how can we reduce the incidence? So I'm going to talk just a couple of things. See, all of you are quite clever and quite experienced, so I will not waste your time talking about how to reduce, but I might give you a bit of an idea about what's the best imaging, when to do what, and what treatment to do for these aneurysms. Okay, now I as my respected speaker initially said, all punctures, 90% of my procedures are through the femoral artery, and all of them are ultrasound-guided punctures. I think it's a no-brainer. If it's a very simple skill to learn, you can visualize the femoral artery properly and a good mid-anterior wall puncture and not going into the posterior wall. So using ultrasound guidance, mid-common femoral artery is very important. Now, the other thing I have to tell you about is the closure device. I'll talk about that in a bit. You have to know your closure device well, because most of the time, if you see the pseudoaneurysms, there are two reasons. One, the puncture may be a bit off target, or it was a difficult puncture, or you have attempted to use a closure device and that has not worked. So it's very important that you take your own time knowing about a closure device and learning about it. Punctures, that the picture on the left is just it's a picture of the internet. It's not my picture. That's a picture showing the femoral artery, and you can see it. It's quite an easy puncture. Some of the doctors, especially the cardiologists, who probably haven't used ultrasound as much, sometimes they take a very easy radial puncture first, in case you need a big sheath for a particular procedure you're doing, and you want to puncture. Sometimes they use a radial access, take a fluoro from above, and then puncture the common femoral artery using the fluoro. It's not recommended because you don't know exactly what you're puncturing. So ultrasound is the best by far. Okay, now just to, again, this is a completely different talk, so I will not be wasting your time on this. Closure devices, just remember the collagen-based, suture-based, and metallic clip. Obviously, collagen-based, you have got the obtura, which we use commonly, and then you've got the angioseal. Suture-based ProGlide has changed the whole concept of closures. We can use it for aortic aneurysms, a lot of PVAs that we are doing. And there are metal clips. See, a very small point I'll tell you is people who are using ProGlide sutures or any suture based or any sort of device, always good to dissect the fat up to the arterial wall if you can see. It's just because, you know, in whatever device you use, be it suture or collagen, you can have a bit of soft tissue stuck in between the anterior wall and the suture device. So always try and dissect, just blunt dissection. It's very simple forceps is enough. And that saves you a lot of trouble. Otherwise, you don't get a complete closure. Okay, now let's come to the topic. That's just a bit of a prelude. Imaging, I'll keep it very simple. For all stable patients, you're suspecting a pseudoaneurysm, ultrasound is the best, and it's enough. Stable patient, you cannot see an ultrasound because there's too large a hematoma. You're still considering a pseudoaneurysm, do a CT. Now, some of your patients may have renal problems, and what do you do then? You cannot do ultrasound, you cannot do a CT. You can do something called an MR TOF, like a time of flight angiography, where you don't use any contrast. You get a fair amount of idea if there's a pseudoaneurysm or not. But let me tell you this, 99% of, or let's say that's a bit of an overestimate, 90% of the time you can see your pseudoaneurysm on ultrasound if you are good at it. Unstable patient who can be shifted, I would suggest a CT straight away. Just because you really want to know what's happening and you really want to get into the root of the problem as soon as possible. So a CT is the best. All, you know, your renal functions, renal failure, everything goes out of the window. Unstable patient, shiftable, CT. Unstable patient, not shiftable to CT. That's CT is, let's say, in the it's in the underground flow, and the cardiac ICU is in the first floor. Ultrasound by a senior doctor, and then shift to the cath lab for contralateral access. This is for unstable patient, not shiftable to CT. May I have a small point about this, is that this patient can also go straight to theatre if you think it's, he cannot wait any longer, so they can just quickly get to the problem. So is that clear, this slide? Okay, now when to do what? Okay, so there are a few things. There's conservative follow-up, there's ultrasound guided compression, there's percutaneous thrombin injection, there's endovascular and open repair. So we'll go through each one. This thing. Now, conservative follow-up, I should say, it's, when can you use it? If it's very, very small, barely visible, but it's there. It's like a small, broad-based irregularity. That is that's what I think is a small one, which for a stable patient, you can follow up, maybe 1 week follow-up. You can do that. But, I don't think the pseudoaneurysms which we get called for or which you have to see are these type. So it's very rarely you see a patient for this. Now, there are a lot of papers. In fact, I didn't know about it. I was just searching about it last night, just looking as to what are the papers supporting and all this stuff. And there are a lot of case study papers saying that anything less than 2 centimeter can be followed up without any treatment. I completely disagree with it. Just because 2 centimeters is quite a big. 1.5 centimeter pseudoaneurysm is quite a big pseudoaneurysm compared to what the common femoral artery size is. It's important that we also think what the neck is. So I don't think for anything for up to 2 centimeters should be followed up. It should be treated. Ultrasound guided compression. Now, this is a horrible thing to do, but this sometimes saves us. It's actually a very common thing. Even we also do it. You can try for the conservative group. If it's a single thin patient, small hematoma, you can see the neck of the aneurysm. It's important that some people when we're compressing, we start compressing the sac. That will not do you any good. The idea is to compress the neck of the pseudoaneurysm so that the flow doesn't go, and you compress it for about 10 minutes, maximum 10 minutes compression cycles for a maximum of about 30 minutes. So for which ones you can use ultrasound? If that's single lobed, they're long and thin neck, so you've got a good chance of compressing it. You can use that. But the problem with this is it's too painful for the patient, and the person who's actually doing it, it's very difficult, because if it's a bit of a bigger patient, you're trying to hold the curvilinear probe, or the linear probe, it just slips, and although you half the time you're doing it just because you want to try it. So I would rather, do something else. So this is one thing which does help, but only to a certain extent. And the patients won't be happy. It's very painful. For me, this percutaneous thrombin injection, when to consider. This is, I think, by far the best, and it's changed how we manage pseudoaneurysms in many cases, and not only femoral artery, in the other ones where in the mesenteric and things like that, we have used this under ultrasound guidance. So, stable or unstable patients, attempt can be made with percutaneous thrombin injection. See, all pseudoaneurysms with a rent, as in the puncture site less than 3 mm, it's quite a safe to use percutaneous thrombin injection. Bilobed or trilobed, you might have bilobed or trilobed aneurysms, you can use that, okay? And then if it's more than 3 mm, you have to use a balloon protection. I just want to give this slide quickly to you. Percutaneous thrombin injection not to consider if there's more than 5 mm, large hematoma, complex neck, okay, posterior pseudoaneurysms, infected abscesses, you do not use thrombin injection. Okay, you go straight in for a thing. So imagine injection is into the neck. I'll skip that because of time. Endovascular coiling. So if it's a branch artery, like you saw an inferior epigastric artery, it's better to coil. When you're coiling, make sure you coil distal and proximal to the rent. That's when, if it doesn't stop with coil, you can use a bit of glue or gel foam as my colleague used. This is a fair enough. Covered stent is contraindicated for stable patients. You should not do covered stents for CFA covered stents for patients who got pseudoaneurysms in the common femoral artery. Okay, you can put, think of using apicillary balloon. So I'll just quickly open repairs for all those patients who are unstable, failed thrombin, large hematomas, people who got compressive neuropathy, and infected groin. You think of an open repair. Now I'll just, I'll take 30-40 seconds. You can see here the pseudoaneurysm neck. So this is the yin-yang sign. So you get that going in and flowing out of the pseudoaneurysm, yin-yang. So this is an aneurysm with a long neck. Now you can see here, so the needle, this is the needle here. So this is the neck. I know this is the neck. So you have to inject very close to the neck so that this is a thrombin injection, okay? You just need it in 0.5. Never think it is not enough and you just keep on injecting 2 or 3 ml. It's very important because that thrombin might be escaping into your arteries. So just 0.5 to 1 ml is enough, irrespective of size of sac, because all what you're doing is obliterating the neck of the pseudoaneurysm. Okay, so I'll just quickly show you that. Sorry. Yeah. So you can see how the thrombin, when injecting thrombin, how it looks. And so that's a thrombosed aneurysm, roughly. You can see on the
running
on the
a
screen
bit
it's
short of
completely
time.
thrombosed off.
A little short of time.
Yeah, okay, fine.
Great. I think the best treatment for pseudoaneurysm is the prevention of pseudoaneurysm. Like
Correct,
you have to know how to puncture.
Agree.
Maybe in the future you'll have a robotics, microparticle nanorobots like your artificial RBC. If you inject through the vein, that will circulate, and you put the ultrasound, you can see better. And second trick will be scratch the needle, like Didier from France. He has shown that in TAVR, if you scratch the needle multiple times with a blade, and you put the ultrasound, you can see the architecture of the radiopacity of the needle better.
Yeah.
So that you can avoid the calcium. But pseudoaneurysm, in my experience, most of the time is ultrasonic compression, manual complete works. Thank you.
Thank you.
Yeah, thank you very much. We are really short in time, but just want to mention that I really agree fully that ultrasound compression or leaving patients overnight with compressed, it never works really well. So I have done thrombin injections 25 years ago.
Yeah.
The most impressive is if you make the image with the color.
Correct. I had that quote, yeah.
Okay. Thank you very much.
Okay. Thank you. Thanks.
So we will continue with dissections and perforations inside the coronaries, and Dr. Natarajan will tell us about that. We don't want to see that, but it happens.
So in the next 10 minutes, we'll talk about an approach to dissections in the coronary arteries during interventions. Dissections and perforations are known complications of PCI. more so in complex lesion subsets. If you look at the epidemiology of mechanical complications during PCI, abrupt vessel closure is often due to dissection. Fortunately, the incidence is only 0.3%, and emergent surgery is needed only in 2%. The death is less than 1%. Perforation has more a worse prognosis. Coronary dissections can be primary coronary dissections or de novo, or secondary coronary artery dissections, which are iatrogenic. Iatrogenic coronary artery dissections can occur during the course of diagnostic coronary angiography as well as during percutaneous intervention. They are often due to hardware-induced dissections, which can be due to the catheter, either diagnostic or a guiding catheter, the guide wire, the balloon, stents, adjunctive equipments like guide extension catheters, imaging probes, atherectomy devices. All these can contribute to iatrogenic dissections. This is an example of a spiral dissection in the right coronary artery. Coronary dissections can further be classified into intracoronary dissections within the artery that is being intervened during the course of percutaneous intervention, or it can be iatrogenic iotocoronary dissections. And these are often due to catheters. And intracoronary dissections, in fact, one of the ways in which PCI works itself is by creating dissections. So it's quite common during PCI. However, if it is due to a subintimal wire passage, it can cause abrupt vessel closure. So you need to redirect the wire into the true lumen to stent and seal the dissection. Can be balloon inflation related, which is how a balloon angioplasty works. Can of course be an edge dissection after stenting the target location, and edge dissections after stent implantation minimized by deploying the stent edge in normal or fibrous tissue, and to avoid deploying a stent edge in lipid-rich plaques with tin cap fibrothroma. And if significant, an edge dissection, you have to put an additional stent. And we now have imaging criteria as to when to put an extra stent in the event of an edge dissection. We have certain criteria, for example, in the OCT image, if the dissection angle is more than 60 degrees, if the length of the flap is more than 2 millimeter, if it causes the luminal narrowing less than 4 square millimeter. These are all indications to put an extra stent to cover the edge dissection. In minor forms of dissection, you don't have to actually do anything. These are some examples of minor edge dissections which during follow-up completely heal. Iatrogenic iotocoronary dissections are a different ball game. This involves osteoproximal coronaries, for example, the left main or the osteoproximal RCA. It can also extend retrogradely into the aortic sinus of valsalva, into the aortic root, sometimes even into the ascending aorta, the arch, or even the descending thoracic aorta and abdominal aorta in rare cases. The causes of iatrogenic iotocoronary dissections are often due to non-coaxiality of the guiding catheters with forcible injection of contrast, use of guide extension catheters, small aortic root dimensions, ostial coronary artery disease, calcific ostial coronary artery disease, aggressive manipulation of large size catheters, supportive guide catheters like the Amplatz catheter, which can dig in deeper and cause a traumatic dissection, telescoping of guide catheter during withdrawal of, for example, a jailed wire in a side branch. All these can contribute to iatrogenic iotocoronary dissections. This is an example of a damped pressure. If somebody injects a contrast forcibly when the catheter shows this kind of pressure, you are inviting trouble, it can cause dissection. So always you have to relax the guide catheter. It's good to look at the arterial pressure waveform before making forcible injections to prevent iatrogenic iotocoronary dissections. And these dissections can propagate antegradely into the coronary artery and cause abrupt vessel closure, or it can retrogradely propagate, as I already told you, into the aortic root, ascending aorta, and even further down. This is an example of an antegrade extension of the dissection flap causing total occlusion of the right coronary artery induced by a guide catheter. The National Heart, Lung and Blood Institute has classified intimal tears into A, B, C and D depending on the extent of the dissection and the flow compromise of the target artery. These are some examples of left main dissections of various types. This is a patient who had an angioplasty to the LAD as well as to the circumflex And after that, we saw this. There is a dissection in the roof of the left main with diastasis there. So this is an example of a guide catheter-induced left main dissection, and this was covered with a stent, and this patient could be salvaged at the end of this process. So you have to recognize these things. You have to be meticulous in looking for these dissections, and of course be prepared to tackle them to salvage. And this is yet another classification by Dunning into class 1, 2, and 3. This is confined to the ostium in class 1. If it extends into the sinus as well as the aorta, but less than 4 centimeters, it is class 2. However, if the extension is more than 40 millimeters, it is more serious. Sometimes it may even need surgical repair. This is an example of a Dunning class 3 dissection of the right coronary artery, where there is an extension of the dissection into more than 4 centimeters in the ascending aorta. And there are various classification schemes. We won't go into the details. One of the ways to salvage is what was proposed as a 4S strategy in iatrogenic coronary artery dissection. One is maintain a stable emotion, don't get panicky, keep the guide catheter and the guide wire stable. In panic, you should not remove the guide wire because the guide wire can be a savior. And one should keep a cool and smart head. It should perform stenting in the vessel with more hemodynamic compromise, as in the case of a left main into the circ or LED can be decided based on which is the larger vessel, where there is more slow flow, etc. You can do the stenting in that vessel first, and then you can pay attention to the other vessel. You have to be quick, obviously. You have to resort to temporary pacing, electrical cardioversion, intubation, so on and so forth. And of course, bailout immediate stenting is the optimal option to save life in most patients. This is a representative case example of an aorta coronary dissection of the right coronary artery treated successfully with stenting of the RCA. You can see that there is a shepherd crook of the proximal RCA with a critical lesion there. And after the guide catheter, there is a bad dissection with staining of the root as well as the sinus and extending into the proximal ascending aorta. So this is a classic definition of an aorta coronary dissection after a guide. This is just to show that this is the false lumen in the inferior aspect, and on top is a true lumen. This is very important to recognize because the key to salvage these patients is to wire into the true lumen. This is just a blown up to show that this is the false lumen and this is the true lumen. And sometimes you may have to leave a wire in the false lumen and keep another wire to successfully wire the true lumen, as was done in this case, and a drug-eluting stent to seal the dissection right from the ostium with reasonable angiographic vessel with TIMI3 flow in the RC at the end of this procedure. It's also good to do a CT imaging to see the extent of the dissection into the aortic root as is seen here. In the immediate contrast CT, you can see that this is the stent, and you see a dissection of the right coronary sinus. You see a false lumen in the ascending aorta here. But the very next day, a repeat CT shows that there is significant resolution of the dissection here as well as in the ascending aorta. So you can be comfortable at the end of this procedure after this repeat imaging. So it just underlines the importance of doing a CT imaging during follow-up, especially if there is an extension of the dissection into the proximal ascending aorta. So I'll conclude by saying that iatrogenic dissections of the coronaries are rare, but they have the potential to cause acute vessel closure, myocardial infarction, and even death in some cases. Expeditious wiring of the true lumen is the ultimate key in guide wire induced or guide catheter induced dissections. Stenting into the true lumen with sealing of the dissection flap is the solution. Prevention of aortocoronary dissection by gentle handling of the guiding catheter, sticking to the basics, is even more important than actually treating these patients. Edge dissections after stenting can be picked up angiographically by meticulous observation, like we saw in the left main dissection in that particular patient. Of course, further delineated and confirmed by imaging if you have access to imaging to assess the need for additional stenting. Every operator must be vigilant of procedural complications like dissections, perforations, be aware of the corrective measures, be familiar with corrective tools in the cath lab, and keep cool and yet be swift. Thank you for your kind attention.
Thank you, Natarajan. As usual, meticulous and perfect. Keeping the wire is the most important thing, and looking after the hemodynamics. Okay.
Yeah, but I fully agree with most what you said. But tell me, did you have side holes in the right catheter or not?
No, we did not have.
Yeah. Fortunately, Dr. Trehan left because I cannot start this discussion with him in the room, but I fully are convinced that most of the problems with aggressive guides, and I work with Amplats exclusively for the right almost, are not happening when you have side holes. Side holes are not preventing problems, but they are helping getting not into severe problems. And there is a basic rule actually, which I share with Dr. Trehan, is once you have created this dissection, you should actually change your guide. Don't work with the same guide. You managed to do it with the Amplats here by getting a wire in the force loom, but the basic trick is change to a different guide. That holds true for the left and the right system.
Right. So the dissection, the right coronary artery is much weaker subject than the left coronary artery, female. It is completely gone when we switched from femoral to radial by TIC catheter. You never can produce diagnostic catheter-induced dissection with the TIC catheter because, as he has mentioned, the side holes. So all these cases you have shown in the picture from the internet is basically femoral going through the JR catheter. That is one. And second, as he has rightly mentioned, the emplazing any catheter. So the dictum is, if you are facing any resistance and if you do not back bleed your guiding catheter, do not inject. So back bleeding your guiding, see some blood at least. See some blood before attaching it to your host. If you see blood, is a pulsatile flow in the guiding catheter or the diagnostic catheter. Two things are assured. There is no air, no thrombus, and perhaps you are not jutting against any wall. So other things, that once you have dissection, then you have to fix the proximal part. Instead of polymer jacketed wire, you use a different wire, different guide. But most of the cases can be saved. Thank you.
One thing that should be emphasized is that once you find a dissection, stop further antigrade injections as far as possible. They tend to propagate the dissection forward, and what is a simple dissection may turn out to become a complex dissection or even a perforation.
One question, Natarajan. If you have an aortoosteal hematoma which is extending, when will you repeat the second CT? Because you need to know whether it is progressing or not. Do you have to?
See, the case that was shown, the next day itself it completely settled.
Resolved.
See, we have a patient, Dr. Hasra, I don't know whether you'll agree. One of my colleagues, Dr. Rajiv, had a patient after a diagnostic angiogram. There was a dissection which extended all the way to the iliacs. And it's about 15 years now. And the patient is under follow-up and doing well. I don't know.
Nowadays you can do TE also. You can see the aorta nicely if you don't want to give injections, because giving it, but ideally it should wait for 4 to 6 weeks before the whole thing heals.
Thank you, Natarajan.
Thank you.
We'll move on to the next talk. Broken wire, Dr. Karthikeyan.
So can I have my slides, please? Good afternoon. So I'll just run fast. So this was a 72-year-old lady who had anterior wall MI, thrombolized, and then fixed the LAD. And then this was the problem. At the end of the case, we realized that the support wire, which was in the circumflex, had broken. And fortunately, it was a clean cut. So how do we retrieve it? So this was the traditional twisting wire technique of removal. But then, all of us know how to, you need two wires and twist. But then what really helped us was a large bore torquer. So you could hold both the wires and give it more twist. And that gives you more grip. This is the only nuance I just want to add. Next, pushing the wire down is much easier. Pulling it back coaxially, especially into a roomy left main, is difficult. And you don't get control. And if you may not be able to get it right into the guide. And it may float in the polygon of confluence, something like this. And I kept on trying. And then at some point, you have to listen to your colleagues. So my technician said, if you can control with 2 wires, why not with 2 balloons? So with 2 small balloons, this was just fished out. And you can see this wire floating in the aorta. And the next, systole, it was down here. So I showed this on the day 1. Now this is something, the snare sheath goes, I was trying to actually snare, but then the sheath itself kind of telescoped it. So now what I'm trying to show here is that if a guide liner was there and if the wire was too distal, I could have just used a guide liner, telescoped it, and taken it out from the coronary itself. So this is another trick. And this was safely taken out. So the lessons learned was have SOPs in place for problem. The whole team needs to be sensitized in firefighting. Pushing for wire fragment to distal vessel is much more easier. In a roomy vessel, there's difficulty in grasping the wire. Retrieving the fragment to guide is a difficult process, en masse removal of the system. And Guidezilla assisted telescoping, grasping of the fragment with a balloon, and removal of the system in toto. And worst case scenario, you can push the wire into distal branch and plaster it on the wall with a stent. So all these are possibilities. So next one was bifurcation, then stented. I did a pot to realize that my branch wire is broken. The only good thing was I was using a torquer to retrieve it, so it was another clean cut. And I got into the branch, but then I realized that what are we trying to achieve? It's very much secured and behind the vessel. And this is a small, compared to the stented branch, this was a small vessel. So I decided to leave it alone. Patient is on follow-up almost for 4 years. Nothing has happened. So sometimes it's better to leave the wire fragment if it's in a secure location. And this case I'm just showing, not for, I know this is a chip course, but then to know and also identify problems. Because you see this is actually an unfortunate case where the coiled wire broke in the LA. This was after a successful BMV. So it's even a stiff wire can be broken. Usually you know that the coiled wire breaks in the junction, but a stiff part of the wire can also be broken. And why this happened? So you keep on reflecting on why this happened. Of course, this is not relevant now, but what was actually the problem was, I was trying to retrieve this bent wire into a catheter with a small lumen. So the kink got exacerbated and then the wire snapped. So I re-entered. And how do you snare out? Because now we have a sharp end and a soft end. So when you snare, you must know which part you can control and which part will give you a problem. So there is a soft end and there is a hard end. And this hard end is something which you need to telescope and take it out safely. So a Judkins ride goes in to the transeptal puncture and a snare, and take a snare which you are familiar with. And now I've caught the soft portion, and then I snare and telescope so that the sharp end is telescoped back. So this is just a philosophical thing, so that when we have a fragment, we must know whether we are dealing with which one to control and which one to telescope. So my lessons learned was it's not finally over. It's over till not over till it's finally over. Retrieving a bent wire is always into a catheter with large lumen. Never lose access to a chamber of interest, and safe retrieval of broken fragment by snaring and telescoping. And this is another case where we broke the wire in the vein and removed the access site, because once the balloon comes out, you just have an arteriotomy, and so the ideal thing, you could go from the opposite side, snare it out, but then it was so close and the arteriotomy is very much open. So with just like how a surgeon would do it, so we just retrieved it because we had the hand-eye and multiple views, of course, I took, and then retrieved this fragment. So I just shared my mistakes and misfortunes so that it will hopefully prevent a similar complication or a delay in firefighting. It's better to know what will not work, and deja vu phenomenon is useful when you encounter a problem. So I hope when you see something like this, you will have some, will know what next can be done. Have protocols, simulate experience, and complication drills in place for rare occurrences. And investment in bailout tools is like insurance for an accident. It's worth it, because I didn't have a coronary snare that day. That gave me 1 hour of extra work to retrieve that fragment. And any of our arsenal can become a bailout tool. So you just have to sometimes innovate. 2 balloons to hold a wire fragment is not something which we normally do, but then sometimes can save the day. Thank you very much for your patience.
Yeah, thank you very much. We all hope that our wires stay intact, but I know that some incidences here are probably because some wires are under continuous stress. I don't want to go into too more details. But that's certainly one problem, but it happens with New York wires as well, I know. And I think one important point is to decide whether it's really worth all the effort to get it out. So the important part is to know where is the broken part. So it's also important to look at the wire part that you have externalized, or taken out to compare
Yes.
how much is left. That is, I think,
Yes.
very important decision.
Yes. In fact, both the coronary wires which was damaged, the retrieval part was done with a torquer. So you keep on torquing. So in case also what happens is you get a clean cut. The idea is, instead of fragments, that metallic thing which is shimmering all the way, it's better to get a clean cut somewhere so that, and then retrieve, kind of compare. So both the wires which are cut was clean.
Yeah. Nowadays, there are ACT technology of Asahi. That is, there is no welding in between, like BMW. Whatever trash you have left inside the heart, if you can measure it, please measure it. For example, if you have at the welding point broken, take out the rest of the wire, take another fresh wire of same make, BMW, and put it side by side. You get to know how much is inside. Suppose it is 100 minus 10, so you know that 90 is inside. Then you can trap with the balloon.
Yeah.
So that is one. There are many tricks of removing the wire. You have mentioned that single, twee, etc. But people have, like David Warner, when he started doing it, those days, there are many coronary trash left inside coronary. Anthony Colombo, Samu Matthew, Loshok said, they have left this coronary without any consequences.
True.
But it should be a fair attempt to retrieve as much as possible. If you have something like threads inside your aorta, you cannot see those. So what you do, you put a very big snares. Just imagine that some threads are just floating inside the aorta, and if you catch those threads with a bigger snare, perhaps you can retrieve. So there are many tricks, but if you know all the tricks, sometimes you have to take help of all these tricks, and most of the time you're successful. Thank you.
Thank you.
Yeah, thank you very much. So we will continue with non-deflatable balloons. Dr. George will tell us how he manages the problem.
Yeah, thank you. So right from stuck wires, I'll move to stuck balloons. So I'll just start with a case like this is a very 70 years old gentleman with a very tortuous calcified long RCA with lesion involving both the proximal, mid as well as the distal, which definitely needs a plaque modification, a calcium modification. So he underwent a rotor ablation with a 1.5 burr with a temporary support, pacemaker support. But still, if you see that after the temporary support, the balloon crossed, but you can see that heart rate coming down and patient again going in for a transient arrest, which required a cardiopulmonary resuscitation and was revived. Fortunately, they had a temporary pacemaker, but the catheter just moved out and it was not, again, we had to again downgrade to a JR catheter, but wired it up. It's an open vessel, so wired it up, multiple wires, but still the stent not crossing up. So again, the block modification required with multiple balloons, including cutting balloons, as well as NC balloons. So that is what we are seeing out over here. And finally, you can see that the stents have crossed with a balloon support, distal anchoring balloon support. The first stent crossed as well as the second stent deployed. So that was, it looks fine. The results also after an arrest as well as with an atherectomy as well as balloons. So, but still in your mind, like having a lesion, long lesion with multiple stents, you definitely think of more optimizing it or getting a better results. So you go with a post-dilatation. This was a 4 balloon, an Oxford 4 balloon, I would say, like I think Dr. Warner would dash me before that. And yet also that the story begins over here with a 4 balloon. So 412 balloon, you inflated up and now you are in trouble. So what to do in those situations out? Either you do multiple, the inflator is something which comes to your help anyway at all. You go at a very higher pressure, try to burst the pressure, burst the balloon, or again you give multiple negative pressures and try again inflating, deflating and see it out anyway at all. If that doesn't work out, you add on a syringe over there, a large 20 cc syringe, and try to get a vacuum pressure over there with multiple negative times. And I would say in 50% of cases like this, I think that works out anyway at all. At least you get some negative pressure
and the balloon deflates out so that it gives you some space for.
Use penumbra.
Okay, right.
Because the suction in the normal syringe, maximum you can achieve 30. Penumbra gives 50 plus.
50 plus, okay, right. So yeah, that's a good point anyway at all. So that also can be added up. So at least like, especially in proximal balloons, I think it'll most of the time it gets out. But when it's very distal, it may take some more time out anyway at all. So those things were tried but did not work out. Another thing is now parallel wire technique, whether you can pass a wire across this inflated balloon and try putting another balloon down there and try taking it out. So all those things. So that is something out there. There's a balloon guide trapping which was tried, especially when a shaft gets broken up also. So you can put a balloon over there at the proximal part or the tip of the catheter and try taking it out with the balloon guide tap technique. Or the balloon trap technique is either you can pass the wire, you can pass a small balloon distally and then inflate it up at 4 to 6 atmospheres and try taking up the undeflated balloon. That is another technique, which is the distal buddy balloon trap. Or parallel balloon, if it doesn't crosses up also, you can use a smaller balloon and try dilating so that the undeflated balloon slightly gets deflated and you can take it up. Distal braid induced balloon perforation is something when you have a guide extension catheter which has got braided ends, the tip needs to be cut off. Once the tip is cut off, you got pointed ends, which like a mother and child catheter or a guide extension catheter, you can pass on. And the tips are quite, you need to keep the tip pointed up. This is something, catheter is a 4 to 5 French catheter, which with a guide with a extension guide, which can be passed on, and it should be passed together with the balloon tip cut so that the tip of the pointed area, you see over there, those tips should be pointed up so that they will rupture the balloon and in a way like deflate it up, if not completely, at least partially. So that is another thing which need to try. Another one is a coronary snare retrieval, which was tried over there. We can pass the coronary snare and capture the balloon, if at all from the distal end, that is good. If it doesn't cross up to the distal, at least at the mid or proximal area, which is what is going to try over here, it may cause some deflation and get this balloon out. So coronary snare retrieval is something, if coronary snare is available in the lab, which could be done out and at least deflating in partially so that the balloon comes out. So this is the snare technique, which is trying to get the the non-deflated balloon out. And you can see that slowly the balloon gets partially deflated and it comes out. So that's reached the osteoproximal part and it's completely retrieved. An important thing is you've got to take it intact, the wire as well as the balloon, because you need to take it out through the site. Ideally, larger sites are always better. Just go back, sorry. So you definitely need to have a femoral site if possible so that you can get these wires and retract them. If at all it's getting not going through these sheets, and you better keep it up because the coronary, you need to check out what happened out because it could be having a dissection, a perforation, or a slow flow, all those things. You can see a thrombus over there because of the long time procedure, as well as the ACT also, it need to be maintained up. So that was done, and luckily this time there's a New York balloon which just post dilated over there, and that's the final result. And once that is settled, because you're making nitrogenic MI in these patients when you don't have any other stuck balloon, so when that is settled down with the flow maintained, you can still go down and then take your balloon out through the femoral site, or even you can upgrade your catheter distally and take the balloon or wire intact out. So undeflated balloon is always, multiple options are there. You can either rupture the balloon with a ultra high pressure, burst it up. You can use distal braid extension catheters, which can suck it up or rupture the balloon out. And maybe not very useful, just pulling up along with the guide catheter, maybe the last option if at all the patient becomes unstable. Otherwise, you may need to snare it out, or you may need to send it for a surgical thing. Rupturing it with a CTO or the hard end of the O135 wire is tried up, but may cause complications. So may not be a good option of choice. and conservative, especially in very distal vessels only, may be tried, but may not be a good option also. So I would like to end up saying, like, and especially when you're using a large size balloon, always make sure that deflates well. Use a good balloon. Don't panic. Stabilize the patient. Always call for extra help, because these are patients who are iatrogenically causing a myocardial infarction, which may collapse up. So stabilize the patient for the time when these balloons could be taken up. Indiflator, syringe, vacuum, or all those things definitely adds up. Guide extension catheter, snakes, snares, keep in the shelf, always are needy things. So that's it now. Thank you.
Thank you, Jimmy. It was wonderful. I've seen a case presentation where the undeflated balloon was in the proximal RCA and the guide was deep intubated. The moment the guide touched the balloon, it
deflated out. Right. Yeah. If it's a proximal, it's like a guide extension catheter or like a guide, or you can even downregulate the guide from 6 French to 5 French, which may sometimes also helps out anyway.
This poking it with the back end of the wire. We have tried it outside. But it doesn't work.
It doesn't work because it's moving. The balloon moves, isn't it? Out, so may not work out.
It's more of theory than it doesn't work.
Yeah. And maybe it may perforate the vessel also.
Yeah, I haven't had the situation to try to puncture, but I don't quite understand why it wouldn't be an option to use a CTO wire, like an 14 gram or 20 gram wire, and point towards this large target.
But
there are no reports that that doesn't work, or?
But does the balloon stay like that? Because you've got air as well as the contrast inside. So you're going to poke up there, it's going to move to the other direction. So
no, I think what he is trying to say.
Yeah,
first,
I'm just curious because you said it's not advised.
No, I have a suggestion. Like maybe something like whether we can use something so that exact area where we can point it up. So that
if you use electrosurgery wire like Astado 20, like what we use for Sesame and Lampoon in structural heart disease, if you use a regular CTO wire, if you put your back and you cannot see. Whereas Astado 20, you can see the tip because it is 20 gram. And you dilute the balloon contrast by giving saline, putting that thing, you have to use saline so that you dilute it. Your contrast is also diluted in the hypotube. Sometimes inside the balloon may reach. So all these things maneuvers should be done simultaneously, but it's always not 1 + 1 = 2 in medical science. Maybe 1 + 1 = 3 sometimes. Like if you use this Astado wire, it will work. Sometimes it do not work. So you have to know all. Yes.
Actually, for this balloon deflation failure, it's reported that take a microcatheter and a wire like Confianza Pro 12, you can kind of. But the problem is the forces are not aligned. So many times it may work outside, but inside may not work. The second thing is just breaking the shaft. That will give a little bit pressure. Some 1 or 2 drops will go out, and then you will get some space. And then you can take your straight catheter across and finish the job. Yeah, because many times you are not trying anything here, but once you just get that shaft broken, you can just twist and turn, break it, and then that 1 drop which comes out will give you that enough thing to take your guide extension or the straight catheter. But the only problem with the straight catheter is only 10 centimeters can go in. So if you are with the proximal 10 centimeters, the straight catheter will work.
Can a Stingray balloon, if it crosses, because it's got almost 180 degree, it's facing the balloon, then like you can pass your 20 grams wire or 14 grams wire. Will it be a useful thing if you can go to Stingray inside? Like
Stingray or the recross, anything.
No, the thing is like it's facing this side. Stingray is 180 degree facing. That's why I was just saying.
The alignment of the forces should be that your thing is, it hits. So many times your alignment will be perpendicular. Your force will not be adequately transmitted.
That's why it should have something which at the middle, if the Stingray crosses the middle of the balloon and then you get a wire, but you should not perforate the vessel. It should be the other direction, 180 degree, and perforate it out.
Jimmy, try it out in your next case and then present it for the next chip.
Hopefully not.
Yeah, thank you very much. So after we damaged wires and balloons, of course, logically, the end of the story will be the stent that causes us trouble. Dr. Anand Kumar will tell us how to retrieve the lost stents.
Aussies has won the toss and elected to field.
Yeah, thank you. So I am the last person standing between you and your appetite for food or cricket. So I think incidence of lost stents or stuck stents is very much reducing. It's now supposed to be less than 1%. And this is a meta-analysis of multiple studies available now. What they say is that the coronary stent cannot be taken out from the coronary tree, around 60% chance of complications. But if the stent is lost in the peripherally embolized stents, when you long-term follow-up, practically no complications. So the first point is that if you have a lost stent or a stuck stent, try to remove it from the coronary tree. That's the primary aim. So we also have PCR course. I've taken most of my slides from the PCR course, how to manage this stuck stent or lost stent. So we have two categories. One with the guide wire preserved, whether with or without balloon, and one where the guide wire is lost. That can be in the coronary or that can be in the aorta. So I think I'm seeing only experienced operators in the crowd. So I think use all your armamentarium. You try to have all the snares and microcatheters, have all the clear stents, stent boost, DSA, use everything, high definition imaging. And always try to upsize sheaths. If it's a femoral sheath, try to make it to 8 or 9 French. Radial sheath, if possible, to 7 or 8 French. And also, when you change the sheath, you try to put an extra parallel wire for maintaining access, because sometimes you may have to pull everything in sheath, including the sheath. So you have to keep the access. You try to have a parallel wire for access. And sometimes this is a very helpful tool. If you cannot increase your access, if you, for example, a radial sheath, if you cannot increase, you can take a 4 French sheath and you can make some cuts like this, like a flower petal, and put it through the sheath just beyond, so that the crumbled stent and all can come into this 4 French sheath, and then you can pull back into the 6 French sheath and remove in toto. This is a useful tip described. And in the partial stent loss, you can see the two centers. I think all of us know the first step is try to inflate the stent balloon itself to 3 atmospheres. So this the pressure they are given is increased only to 3 atmospheres. So 3 atmospheres does not enlarge the stent size, so you may be able to get it through the guide catheter. Suppose the stent balloon is not able to catch, or you cannot engage the stent balloon, then use a 1.5 millimeter balloon. If possible, a long balloon like 15 or 20 balloon. And always use a low profile, single marker balloon. So either you can use the stent balloon. If the stent balloon is lost, you try to use a 1.5 millimeter single marker balloon and try to cross distally if possible, if not possible, in the body of the stent. I think this video is not very important. Yeah, I think all of us know the technique. It's just a cartoon. It's not very important. You can just try to slightly deflate and go. Many a time it may not align. You may try to align. If it is alignable, well and good. Otherwise, you have to take the entire system out. So the usual scenario is in a patient with a complex left circumflex, where there is a bend in the mostly when you push the stent and pull the stent, you can see the stent get caught in the LMCA, here in the LMCA. And this is the 1.5 millimeter single marker balloon that can be successfully, because the wire is in situ and you have this balloon, then you can take. Then second is the snare technique. Again describes a snare technique. You can put the snare through the same wire and always try to use 2 millimeter micro snare and try to catch the proximal part of the stent, and then try to retrieve it either en bloc or through the catheter. Again, long stent, this is a case, long stent in the RCA, partially lost. You can see the microcatheter, and you have to pull the microcatheter and not the microcatheter, microsnare, sorry, microsnare and into the catheter. There are also other types of retrieval devices. Most others, except microcatheter, others are mostly used for retrieval in the aorta. Somebody has previously mentioned about the use of guide extension catheter. That is also a useful thing. If you can telescope the guide extension, because the guide catheter usually it's very difficult to telescope into the aorta, into the artery. But a guide extension catheter you can sometimes telescope into the left in the coronary and over a stent. If this is possible, then you can use a balloon to expand the stent to the maximum pressure, like this. This patient, you can see the balloon, you can this guide extension, you put a balloon and occlude and take the stent into the extension catheter outside. Then we have the multi-wire technique. Again, you have seen multi-wire technique. If the balloon is the wire is there, you can use the micro wire, 2 wires. And you can rotate it if possible, like previously described, single torquer or double torquer. Try to manipulate and come back into the catheter, and either through the catheter or end block you can remove. So what if all this is not possible? If you cannot use a wire technique or a snare technique or a balloon technique, then you have to see if we can deposit the stent in the coronary artery. If the stent vessel sizing is acceptable, you can try to deploy the stent in the vessel. So for that you have to use a small 1.5 millimeter balloon, then 2 millimeter, 3 millimeter, and upsize stent. Suppose there is a stent vessel mismatch. There are 2 options. The first option is you can use a slightly inflated larger balloon, and you can direct the stent to a anatomically non-critical branch. For example, a stent lost in the LAD. You can try to see if there is a favorably angled diagonal, or in the circumflex a favorably angled OM, and you can try to inflate this 2 millimeter balloon distally, slightly push the stent to a branch and then try to deposit there. But the final option, suppose all the options run out, there's no other option but to crush the stent into the vessel wall using another stent. As far as possible, try to avoid this in the left main. So stent crushing with another stent. So before stent crushing, try to see if you can remove the wire of the previous stent. Sometimes if the wire manipulation causes movement of the stent, then you can partially inflate the second stent, and after fixing the previous stent, you can remove the wire of the previous stent also. So when you use these techniques, always ensure adequate anticoagulation. Sometimes we forget about these points: adequate anticoagulation, and of course align the catheter alignment is very, very important, and always check the stent and balloon integrity after retrieval. The most difficult to retrieve are circumflex and right coronary artery, and this, if the stent is completely lost without a wire, the previous technique like multi-wire and recrossing technique is not recommended because of potentially dangerous problems in the coronary artery. Again, biotomes also not very used, because now we have only usually 50 centimeter biotome which may not reach the coronary. 104 centimeters biotome is not readily available mostly. Suppose stent lost in the aorta or peripheral circulation. So again, this is a problem, because even though meta-analysis have shown that the stents lost in peripheral and aortic circulation, long-term follow-up shows there is no much problems. So it is also written in the meta-analysis that most of the problems are actually created because of the procedures and extra dye, extra contrast, and unnecessary manipulations. So to see whether, first we see whether we can identify that stent. about 15 to 20% in the literature is written that the stent loss, you cannot see it in fluoroscopy. Even on CT scan, it could not be detected where the stent had gone. So one of the important thing is that if possible, if the stent has migrated to a supra-aortic, that is the cerebral vessels, you always try to remove it. You can use the help of a neuroradiologist also. And if the stent can be seen and like that, if cerebral carotid arteries, you try to remove it. If it is above the femoral artery, you try to remove it. If it is below the common artery, use conservative management. Usually it doesn't cause any harm. In this case, you need large snares, or even the commonly used IVC filter snares, which are usually useful in aorta. So again, this is the thing. If the radial axis, you can use a contralateral femoral approach for retrieval, and if it is femoral axis, you can use the contralateral femoral approach. Cerebral circulation, you try to almost retrieve, consider assistance by a neuroradiologist also. In the upper limb arteries, it should be removed if it is in the brachial or above. Radial artery, if you can bring the stent up to radial artery, it's okay if you can deposit there also. So if it is stuck in the brachial or femoral, you always try to come from the femoral and try to retrieve it. Endomyocardial biopsies forceps are useful in peripheral because once it is near the sheath, you can catch hold and remove it. This is one example. One stent, long stent, we tried to put in this lesion about 1 year ago, but the stent got dislodged. It is a 2.5 into 38 mm stent, and we could luckily get a 1.5 mm balloon and bring it up to the radial. So at that, now you can see the stent in the radial. So today, if I was more learned, I would have used a bioptome or a 4 French cut catheter inside, but because the flow was very good, we just deposited there, and now it is more than 1 year and the patient is fine. And without any further preparation, we could actually stent the right coronary artery with another 2.5 into 38 mm onyx stent. So that brings to the question of the different stent, how easy it is for a stent to get dislodged. So there are some comparison, there are some papers comparing different stents. This bench testing trial has come from Korea. Different tests done using stent displacement force and stent dislodgement force. Stent displacement force is a force which can cause even a 1 millimeter displacement of the stent from the balloon. And displacement means a total loss of the stent from the balloon. And you can see 5 stents compared. In this experiment, OR0 had the lowest displacement and dislodgement force, the higher being Resolute Onyx, Energy, Science Sierra. So these are probably these 3 are less likely to dislodge. So I think,
can we come to a conclusion?
Yeah. So I think we all know that prevention is better than cure. In no areas of medicine, I think this is more important than lost stents. All these cases were unavoidable in introspection. Adequate lesion preparation, gentleness of stent manipulation rather than to and fro motion is very important. Long stents, tortuosities, calcifications are all recipe for this. Now we have excellent guides. Extension catheters can go up to even distal vessels. In calcific lesions, always try to use this armamentarium. So primary aim is to remove stent from coronary circulation. That is the primary aim. And secondary aim, if possible, you also remove from cerebral and brachial circulation. Stent deposited in the radial or infrarenal abdominal aorta and branches, not a problem at all. And carefully examine the retrieved stents and for coronary damage. And final resort in coronary is the stent crush. And you always take from cardiologists, vascular surgeons, neurointerventionists. Thank you.
So I think you should not get bogged down by you lost your stent. Once you are able to bring that stent in the iliac artery, be comfortable now. You can take the other route, finish your job from other access, You can have ample time now, sit back. Even a junior can retrieve the stent rather than spending your precious time, because you have to upsize the guide with your Impelaware or your BMB, the Jalebi ware. You can cut the sheath. It takes a lot of time for that preparation of upsizing the sheath size. There are different ways of doing it. But please concentrate on the coronary back again, because you have removed the stent from the coronary that may be dissected, and you may not get time to fix that coronary. So take the other access and finish the case.
Thank you.
Getting the stent back into the guide. Sometimes if the guide is not going, and that is the time when we have to be very careful. One thing, it can damage the stent, or sometimes it can get the stent off the balloon.
Exactly.
Any points? Nothing. I think we come to the end of the session. Thank you, Anand.
Thank you.
You're the last one standing.
Thank you. Thank you.
Thank you very much. This brings us to the end of CHIP Summit 2023.